All right, welcome to the deep dive. We're going to take a focused, clinical look at a challenging condition that often lands on your doorstep with, well, very little warning: sudden sensorineural hearing loss.
And specifically for you, the specialist clinician listening in, we're diving deep into the vast majority of cases where the cause isn't obvious, what we call idiopathic sudden sensorineural hearing loss, or ISSNHL. It's a condition that, despite decades of research, still holds quite a few mysteries.
It really does. Our source material today pulls together insights from the literature, and it highlights that even with over 30 years of dedicated study, I mean, something like a new paper every couple of weeks, pinning down the why for most cases and agreeing on the absolute best treatment remains pretty complex.
Yeah, that sheer volume of research, it really speaks volumes about the persistent challenge, doesn't it? And the significant impact of this condition, too.
Our mission in this deep dive is to go beyond the surface. We're aiming to extract the critical details, the mechanisms, the guidelines, the controversies, and those clinical pearls specifically for your practice, drawing solely from this source material we have.
Think of this as, well, distilling the core knowledge, structured to help you navigate the diagnosis and management of ISSNHL based on the evidence that's presented here.
So here's our roadmap for today. We'll kick things off with the fundamentals, defining ISSNHL, understanding how it presents, and looking at its reported incidence.
Then we'll tackle the complex and often debated theories of what might actually cause it, the idiopathogenesis. Understanding these potential mechanisms is really key, I think, to grasping the rationale behind different treatment approaches.
Which leads us naturally into the therapeutic strategies. We'll meticulously review the evidence presented for the main players: corticosteroids and hyperbaric oxygen therapy, both alone and in combination. We'll dissect the key studies and their findings.
We'll also briefly touch upon other therapies mentioned, walk through the recommended diagnostic workup and patient management principles, and finally, discuss the prognosis and the significant personal and societal burden of hearing loss.
It's definitely a packed agenda, but let's get started. Section 1, Introduction to Sudden Sensorineural Hearing Loss.
Okay, let's begin with the definition. Sudden sensorineural hearing loss is characterized by the abrupt onset of hearing loss. But clinically, we need specific criteria for diagnosis, right?
Right. What are those objective criteria we should be looking for?
Well, the source specifies the critical audiometric definition. It's a hearing loss of at least 30 decibels occurring within a 3-day period, affecting at least 3 contiguous frequencies on an audiogram. That triad: 30 decibels, 3 days, 3 frequencies. That's really fundamental.
So it's not just any sudden decrease in hearing. It has to meet that specific threshold across connected frequencies.
Got it. Exactly. And the typical presentation, it's usually unilateral, so affecting only one ear. Patients often notice it when they wake up, describing it almost like the hearing just vanished overnight. And, importantly, most patients present without morbid audiograms in that ear beforehand, meaning their hearing was normal or close to it. The degree of loss for evaluation is typically measured against the unaffected ear's threshold.
Okay. Beyond the hearing loss itself, what other symptoms should we specifically ask about when taking a history? What else might pop up?
Patients frequently report associated symptoms mentioned in the source. Tinnitus, often described as ringing or buzzing, oral fullness, that kind of plugged-up sensation in the ear, and some might experience dizziness or even true vertigo, the spinning sensation. These symptoms can sometimes give us clues about the extent of inner ear involvement.
Okay, so abrupt onset, 30 decibels over 3 days and 3 frequencies, usually unilateral, often presenting with tinnitus, fullness, or maybe dizziness. And we need to remember about 88% of these cases are idiopathic, no clear cause found.
Precisely. Now let's talk about how common this actually is. The incidence rates presented vary a bit, which might suggest potential underreporting historically. Estimates used to range from about 5 to 20 cases per 100,000 population.
And what does that translate to annually in the United States, roughly?
Using that historical range, it estimates around 4,000 new cases per year in the U.S. Now, calculating from that, it's about 1.3 cases per 100,000 nationally, but it's recognized as much higher in the elderly population, possibly up to 77 cases per 100,000.
So it definitely seems more prevalent as people age. That's quite a jump.
Yes. And more recent literature actually places the annual incidence higher overall, maybe around 27 cases per 100,000 in the U.S. And for the pediatric population specifically, it's reported as about 11 cases per 100,000.
Are studies showing an increasing trend in incidence? Or is it just better reporting?
Well, the source does mention studies suggesting the incidence is increasing, citing figures as high as 160 cases per 100,000 in the elderly. This actually led to the conclusion by Boole, way back in 1984, that ISSNHL is no longer really a rare condition.
And what's the typical age and gender profile according to that bio review?
The mean age of presentation was around 46 to 49 years, with roughly equal distribution between genders. Pretty balanced there.
Any patterns? Like, does it happen more in winter, or is it linked to colds or anything?
The source notes that ISSNHL doesn't appear to have clear seasonal variations or uneven distributions throughout the year. And interestingly, no consistent association with prior or concurrent upper respiratory infections either. This lack of clear temporal or infectious links, well, it makes it harder to understand the triggers, doesn't it?
Yeah, it really does. Before we wrap up this intro section, one crucial point for interpreting treatment studies is the rate of spontaneous recovery. How often does hearing just improve on its own?
Right, that's critical. The spontaneous recovery rate is thought to be somewhere between 30% and 60%. This wide range really underscores the challenge in evaluating treatment efficacy. I mean, a significant portion of patients will get better without any specific intervention, so any treatment has to demonstrate outcomes significantly above this baseline.
Okay, let's quickly recap section 1 then. We defined idiopathic sudden sensorineural hearing loss, ISSNHL, by its abrupt onset and those key audiometric criteria. 30 decibels, 3 days, 3 frequencies, usually unilateral in previously normal hearing ears.
We noted the common associated symptoms like tinnitus, oral fullness, dizziness, and vertigo. Incidence rates vary, but the condition is increasingly recognized as not rare, especially in older adults, affecting men and women about equally around age 46-49 without clear seasonal or URI connections.
And we highlighted that crucial spontaneous recovery rate of 30–60%, which serves as the baseline, the benchmark really, for evaluating any treatment's effectiveness.
Exactly, and that baseline makes the search for effective treatments and the investigation into the cause all the more critical. Let's move into section 2. Idiopathogenesis of ISSNHL. This is where we unpack the potential causes and, well, it's a complex picture.
The quest to understand why ISSNHL happens, it started a long time ago, didn't it? The first scientific report dates back to Declan in 1944.
That's right. And since then, otolaryngologists have diligently investigated. And this has led to the postulation of many different mechanisms. This extensive list of theories really reflects the difficulty in finding one single definitive cause for most cases.
So what are some of the main theories presented in the source? What kind of mechanisms are we talking about?
Well, the list of postulated mechanisms is pretty broad. It includes things like circulatory disturbances, maybe thrombotic, embolic, or spastic events affecting blood flow to the inner ear, ototoxicity, suggesting direct damage from substances, various types of trauma, though, some trauma-related loss might not strictly be idiopathic, neoplasms like acoustic neuromas pressing on the nerve, vascular occlusions, another form of blockage.
Viral infections, too, that seems to come up a lot.
Viral infections, yes, that's a very common theory. Labyrinthine membrane leaks or perilymph fistulas. Associated immune diseases like autoimmune inner ear disease. Abnormal cochlear stress response at the cellular level. Abnormal tissue growth, which could encompass neoplasms again. And just direct cochlear membrane damage.
Wow, that's a really broad spectrum. Blood flow, infection, structure, immunity, tumors. It really emphasizes the potential for multiple pathways leading to the same endpoint, doesn't it?
It does. The sheer variety suggests either there are multiple distinct causes or perhaps common final pathways that result from different initial insults.
Let's focus on some of the key theories discussed in more detail. The source talks about early experiments investigating a hypoxic or oxygen deprivation etiology. What did those animal studies by Lamb and colleagues reveal?
Right. These early studies showed that perilymph PO2, that's the partial pressure of oxygen in the fluid bathing the inner ear structures in the scala tympani, could fall pretty significantly, by 50% to 80% during noise exposure.
So loud noise can lead to low oxygen in the inner ear fluid. What did that mean functionally? Did it affect hearing?
Yeah, it correlated with a prolonged compound action potential latency and a decline in hair cell function by 60% to 70%. The authors proposed that the oxygen-dependent sodium and potassium pumps of the organ of Corti, the hearing sensory organ itself, basically decompensated under low oxygen conditions.
And this pump failure led to damage, actual physical damage.
Yes, they suggested this caused intracellular sodium to accumulate, leading to microstructural damage. You can picture it at the cellular level. Hair cell cilia fusion, synapses and dendrites swelling up, the hair cells contracting and staying depolarized. These are pretty severe cellular changes that would obviously impair hearing. These experiments give us a plausible mechanism linking stress, like noise, hypoxia, and specific cellular pathology.
That gives a concrete cellular picture for one potential mechanism. Let's move to the circulatory derangement theories, which have been prominent for a while.
Right. Bilal's 1980 discussion highlighted the role of occlusive arterial disease, things like blockages or spasms in the tiny arteries supplying the inner ear, suggesting a direct vascular etiology.
And treatments like vasodilators, they stemmed from this theory, presumably.
Exactly. The rationale for using various vascular agents in treatment was directly based on this idea of improving blood flow. Animal studies where they occluded the labyrinthine artery also supported this, showing severe degenerative changes, fibrosis, and hydrops, quite similar to what happens in a human cochlea when it's deprived of blood supply.
Now, there's an intriguing study presented that seems to, well, flip the script a bit on the role of blood pressure.
Yes, the source highlights a 2001 study from the University of Bologna. They looked at blood pressure in young, untreated ISSNHL patients and compared them to healthy controls. And surprisingly, they found both systolic and diastolic blood pressure were significantly lower in the ISSNHL group.
Lower blood pressure, that kind of goes against the idea that high pressure causes damage or blockages, doesn't it?
It does. The authors suggested systemic hypotension, or low blood pressure, as a possible etiology, particularly in young, otherwise healthy individuals. This really challenges the conventional thinking about high blood pressure risks for the cochlea and offers a plausible explanation for sudden loss in people who seem perfectly healthy.
And this finding has a crucial clinical implication then.
It does. It cautions clinicians against using vasodilators in patients who already have low blood pressure and then develop ISSNHL. I mean, if their problem is already low perfusion pressure, further lowering it could potentially be detrimental. The source notes that the inner ear might be particularly vulnerable to hypotension because it has less circulatory autoregulation compared to, say, the brain.
Right, so check the blood pressure before prescribing vasodilators. That's a definite clinical pearl. So the vascular hypothesis remains, but it's complex, potentially involving both occlusion issues and maybe low perfusion pressure in some cases.
Correct. The hypothesis broadly maintains that vascular disruption and the resulting ischemia lead to damage somewhere in the cochlear apparatus or the nerve.
Beyond these direct mechanisms, what about the role of comorbid conditions? We hear a lot about links between hearing loss and cardiovascular health generally.
Yeah, the source points out an interesting recurrence of ISSNHL in individuals with specific comorbid conditions, primarily diabetes mellitus, hypertension, and dyslipidemia.
Is there evidence linking these conditions directly to ISSNHL etiology, not just association?
Well, while a 1996 study linked systolic BP to general age-associated hearing loss, a more direct link to ISSNHL came from a 2010 case control study by Amuni and coworkers. They compared ISSNHL patients to controls and found diabetes mellitus and hypercholesterolemia were significantly more frequent in the ISSNHL group. And critically, the risk of ISSNHL increased with the number of cardiovascular risk factors the person had.
Okay, so a dose-response relationship almost.
Kind of, yeah. Then a 2012 study by Ciccone and colleagues further supported this. They found ISSNHL patients had higher total cholesterol, LDL cholesterol, and also markers of endothelial dysfunction. They concluded this links dyslipidemia and endothelial dysfunction, basically, unhealthy blood vessels to ISSNHL.
So this is suggesting that the underlying processes associated with these cardiovascular risk factors, things like early atherosclerosis or just blood vessel dysfunction, might contribute to ISSNHL.
Exactly. And then we have a really significant finding from the LINS study. They follow patients admitted for ISSNHL and a control group admitted for appendicitis over 5 years.
And what did they find? That sounds important.
They found the stroke rate was significantly higher in the ISSNHL group, 12.7% compared to the control group, which was 8.7%. The stroke hazard was 1.64 times greater for the ISSNHL patients, and this was a highly statistically significant finding.
Wow, that's a major clinical pearl. ISSNHL could actually be an early warning sign for stroke.
It's a powerful suggestion, isn't it? With real implications for long-term patient care. And supporting this, a 2014 study by Osler found elevated neutrophil lymphocyte ratio, or NLR levels, in ISSHL patients regardless of severity. Now, elevated NLR is associated with inflammation and ischemic conditions like stroke or heart attack. This led the authors to suggest NLR might predict other ischemic events and, importantly, to advocate for referring ISSHL patients to cardiology and neurology specialists for follow-up. This is another concrete clinical recommendation coming out of the source material.
So these comorbidities aren't just loosely associated. They point to potential underlying vascular issues that might trigger the ISSNHL and also, worryingly, warn of future systemic events.
Precisely. It looks like a complex intersection of inner ear health and systemic vascular risk factors.
Shifting gears slightly, the source talks about competing multifactorial theories, referencing Glodek's work. What are these main competing ideas?
Well, Glodek and colleagues noted different emphases in the literature. For example, American literature often alludes more to the viral theory, infection of inner ear structures, whereas European literature perhaps more commonly focuses on vascular pathology, impaired inner ear blood flow.
Is there evidence strongly supporting either of these as the primary cause, like definitive proof?
The source notes that while a viral association with vascular pathology has been suggested, there's no definitive serological evidence, like finding specific antibodies, or a clear, consistent response to antiviral treatment reported to specifically support a viral cause in most cases.
So the viral link is still a bit murky. How does Glodek try to integrate these different perspectives?
They proposed potentially interacting theories: immunologic, viral, and vascular etiologies. Their specific hypothesis is that ISSNHL could be a virally stimulated, immunologically mediated paravasculitis.
Okay, break that down. So a virus triggers an immune response that inflames the blood vessels around the inner ear.
That's the idea. They explain the mechanism. Endothelial cells, the lining of the blood vessels, secrete cytokines, these inflammatory messengers. This leads to immunoglobulin deposition around the vessels, which then causes cochlear hypoperfusion, reduced blood flow, and tissue hypoxia, lack of oxygen. This immunopathological paravasculitis leads to ischemia, narrowing or stenosis, and even closure or atresia of inner ear blood vessels.
That's a pretty specific proposed mechanism linking infection, immunity, and vascular compromise. And is there a molecular pathway potentially common to various insults, something tying it all together?
The source introduces abnormal activation of NF-key nuclear factor, capillite chain enhancer of activated B cells, as a potential player. This is a molecular transcription factor, kind of a master switch, that mediates cellular responses to various stresses, infections, mechanical stress, osmotic stress, other insults. It could be a common point where different initial insults converge to cause damage.
So NF-key could be a final common pathway for viral, inflammatory, or maybe stress-related triggers.
That's the thinking. It helps conceptualize how diverse initial problems might ultimately lead to the same outcome of sudden hearing loss.
Okay, let's try to pull together this section on idiopathogenesis. It's clearly complex. We've seen the numerous postulated mechanisms covering circulatory issues, infections, trauma, tumors, immune problems, highlighting the lack of a single cause for most idiopathic cases.
We reviewed experimental evidence for hypoxia from noise exposure leading to specific cellular damage. We debated vascular theories, including that interesting Bologna study suggesting low blood pressure as a possible cause, particularly in young individuals, which has crucial implications for treatment choices, right? Like avoiding vasodilators.
Definitely. We discussed the strong association between ISSNHL and cardiovascular risk factors like diabetes and dyslipidemia, linking them to underlying vascular dysfunction. And that very significant finding that ISSNHL may be an early warning sign for stroke, supported by markers like elevated NLR, leading to recommendations for cardiology and neurology referrals.
And we explored the competing theories: viral, vascular, the immunologic paravasculitis idea, and the potential role of NAKB as a common molecular pathway integrating various stresses.
The key takeaway here seems to be the multifaceted nature of ISSNHL etiology, with no single definitive cause established for the vast majority of idiopathic cases. This inherent uncertainty, well, that's the biggest challenge when it comes to treatment, isn't it?
And that leads us perfectly into Section 3, the challenge in treating ISSNHL stemming directly from this multifactorial idiopathogenesis.
So, because we often don't know the exact cause for a specific patient's ISSNHL, finding a universally effective treatment is inherently difficult. Makes sense.
Absolutely. The source explicitly states that the difficulty in treating ISSNHL is a direct consequence of its multifactorial and often unknown idiopathogenesis. I mean, if you can't pinpoint the underlying problem for that patient in front of you, targeting therapy is largely empirical, isn't it?
How is this reflected in the history of treatment? Does the literature show this uncertainty?
Oh, definitely. It's reflected in the sheer number of approaches that have been tried over the years. The source states that more than 60 different protocols have been put forth for treatment. 60. This huge number really illustrates the lack of a clear consensus and how the various theories about cause have led to all sorts of different therapeutic strategies being explored.
60 protocols. Wow, that's a lot. What are some of the broad categories of treatments that have been explored based on the list provided in our source?
The list is really extensive. It shows the wide net that's been cast trying to find something effective. It includes agents to decrease blood viscosity, like osmotic diuretics, volume expanders, things like dextrin or pentoxifylline, even plasmapheresis, all aimed at improving blood flow. Then there are vasodilator drugs and procedures like histamine, papaverine, nifedipine, carbagin, even things like stellate ganglion blocks, again, targeting blood supply.
Okay, blood flow seems like a major target. What else?
Antiviral agents like acyclovir and belasaclovir, obviously for potential viral causes. Anticoagulants like heparin or sodium enoxaparin for potential clotting issues. Free radical scavenging vitamins like vitamins B, C, and E, presumably addressing oxidative stress. The list also includes a real mix of other agents: antibiotics, ginkgo biloba, magnesium, benzodiazepines, some prostaglandins, IV lidocaine, even things like repeated smallpox vaccinations, interferon alpha, ATP, beta-histine, thrombolytics to break up clots, vinpocetine.
It really is a huge variety. Anything else?
Yeah, even general supportive care like bed rest, salt restriction, increased fluid intake, and of course modification of cardiovascular risk factors, which ties back to the comorbidities we discussed. And then the two main therapies we're going to focus on: corticosteroids and hyperbaric oxygen therapy, HbO2.
Right. With such a vast and varied list of potential treatments, does the source point to any particular protocol or combination standing out based on the evidence? Anything rise above the noise?
Yes, thankfully. Despite this wide array of explored therapies, the source makes a pretty clear statement. Of these many protocols, the one with the greatest efficacy is the combination of corticosteroids and HbO2. This is a key conclusion drawn from the source material and seems to be where the evidence is strongest.
That helps focus our attention dramatically. It really narrows down the field from over 60 approaches to a primary focus on two modalities, especially used together.
Exactly. It suggests that while the underlying cause may remain elusive for many patients, these two therapies, perhaps acting through multiple mechanisms we've discussed, anti-inflammatory, vascular support, direct oxygenation, offer the most promising therapeutic avenue based on the evidence presented in this material.
Okay, let's quickly recap Section 3. The difficulty in treating ISSNHL stems directly from its complex, often unknown cause. This uncertainty has led to over 60 different treatment protocols being explored over time.
And out of this extensive list, the source highlights the combination of corticosteroids and hyperbaric oxygen therapy as having the greatest demonstrated efficacy.
That sets the stage perfectly for our detailed look at the evidence for these two key therapies. Let's start with corticosteroids in Section 4, Rationale and Literature Review.
Right, corticosteroids. They've been a mainstay in ISSNHL treatment for a long time. Their initial rationale was pretty broad, basically leveraging their known anti-inflammatory and anti-edematous effects, reducing swelling and inflammation.
The idea being that inflammation or swelling in the inner ear was contributing to the hearing loss. That was the original thought.
Precisely. The early theory suggested that some kind of inflammatory trigger or insult damaged the cochlea, and steroids would counteract this inflammation, hopefully sparing further damage and maybe even reversing some of it.
Has our understanding of how they actually work in the inner ear become more specific since then? Do we know more about the mechanism?
Yes, it has become more refined. According to the source, the current understanding suggests corticosteroids have a primary role in protecting the cochlea from specific inflammatory mediators like tumor necrosis factor alpha, TNFA, and also nuclear factor capillite chain enhancer of activated B cells, or NFP.
TNFA is a big player in inflammation generally, correct?
It is, yeah. It's a cytokine, a key part of the acute inflammatory response. It's involved in things like fever, apoptotic cell death, cachexia, inflammation related to tumors, viral replication, response to sepsis. It's quite central. And NFKB, as we touched on before, is that protein complex, that molecular switch, responding to various stresses like cytokines, free radicals, bacterial or viral antigens. Corticosteroids intervene by modulating these specific pathways.
So they're acting at a more molecular level on specific inflammatory signals. Do they also have effects related to blood flow, connecting back to those vascular theories?
Yes. The source states they may favorably alter the inner ear milieu by increasing cochlear blood flow and ameliorating or improving cochlear ischemia. So this links their mechanism directly to the vascular and ischemia theories of ISSNHL.
And anything related to inner ear fluid or electrolyte balance, that seems important for function too.
Definitely. They regulate protein synthesis. And importantly, the inner ear has receptors for both glucocorticoids and mineralocorticoids, especially found in structures like the vascular scrovia. Steroid therapy affects inner ear electrolyte and fluid balance there, specifically where sodium and potassium secretion is regulated to maintain the endocochlear membrane potential, that electrical charge needed for the hair cells to function properly.
And the vascular striae is noted as a frequent site of injury in ISSNHL, right?
That's correct. Systemic corticosteroids are believed to improve its function and preserve its morphology, its structure, in those patients who recover. You could almost visualize the vascular striae, the battery of the trochlea, being stabilized and protected by the steroids.
Okay, so the rationale is definitely multifaceted. It's anti-inflammatory by hitting TNFI and NFB, potentially improving blood flow and reducing ischemia, and also affecting electrolyte balance in the crucial vascular scordia, a key injury site.
Exactly. It appears to be more than just general inflammation reduction. It's acting on several relevant pathways.
Let's look at the clinical literature review presented on corticosteroids, section 4.2. Where does the evidence begin? What are the early studies showing?
An early piece mentioned is a 2001 retrospective review by Alexiou and colleagues. This showed better outcomes with corticosteroids combined with vasoactive agents for certain hearing loss configurations, like low, middle, or pancochlear deficits. This provided some initial clinical data supporting the use of steroids, often combined with other therapies back then.
What about the different delivery methods? We hear a lot about intratympanic IT versus systemic steroids.
Right. A 2005 study by Slattery and colleagues looked specifically at IT methylprednisolone as salvage therapy. This was in patients who had already failed oral steroids. They gave 4 IT injections over about a month and found statistically significant improvement in the 4-frequency pure tone average and the speech discrimination score at the 1-month follow-up for the group getting the IT injections.
So IT helped even after oral steroids failed. Any other benefits?
Yes, they also found that improvements in tinnitus were statistically significant in that IT group. So this study supported IT as a potential option after systemic therapy failure.
What about studies comparing IT and systemic as initial therapy or looking at combination up front? That seems like a key question.
Definitely. The source highlights a key 2008 multi-center, double-blind, placebo-controlled randomized study by Battaglia and colleagues. This involved 51 patients, so not huge, but well-designed. They had different groups. One got IT placebo plus high-dose oral prednisone taper. Another got IT steroid injections plus an oral placebo. And a third group got both IT injections and the high-dose oral prednisone taper, the combination group.
What did they find comparing these groups?
The results for the combination group were quite striking. They achieved an average improvement in speech discrimination of 44% with a 40 dB improvement in pure tone average, or PTA. And importantly, this improvement was significantly better compared to the prednisone taper-only group. Logistic regression also revealed the combination group had better odds of hearing recovery than the other groups.
So that specific study strongly supports the combination of IT and oral steroids being better than oral steroids alone.
It does. However, the source also mentions, kind of complicating the picture, that other prospective randomized trials comparing initial IT corticosteroids versus systemic corticosteroids found hearing gains in both groups, but no significant difference between the IT and systemic groups when used as primary therapy in those specific trials. This suggests potential equivalence between IT and systemic as initial therapy, based on some studies.
Okay. That introduces some complexity. Combination might be better than oral alone based on Battaglia, but IT might be equivalent to oral as initial therapy based on others. How do reviews handle this?
It reflects the varying findings across studies, which is common in medical literature. Reviews try to synthesize this. A 2011 comprehensive literature review by Segas and colleagues concluded that topical corticosteroids, meaning IT, can be a valuable treatment. But they found combination therapy results controversial and couldn't definitively say if IT was superior to systemic. They actually called for establishing standard criteria for hearing recovery, which was lacking.
Okay, so one review found it valuable but controversial. What about others?
Another systematic review in 2011 by Spears and Schwartz identified 32 studies focusing on IT steroids, either initial or salvage. For salvage IT treatment, the majority of studies showed at least some benefit. The average IT salvage benefit they calculated was a 13.3 dB improvement, although the authors debated whether this difference was clinically significant for the patient.
And what did Spears and Schwartz conclude about initial IT versus systemic?
For initial therapy, they concluded IT steroid therapy was equivalent to treatment with a high-dose oral prednisone taper. So their conclusion aligned with some of the individual trials suggesting equivalence for first-line use.
Right. So these reviews are generally supporting IT salvage benefit, though the clinical significance of the average gain is debated and suggesting initial IT is probably equivalent to systemic. This contrasts a bit with the Battaglia RCT that strongly supported combination being better than oral alone.
That's a fair summary of the differing perspectives presented in the sources review up to this point. It highlights the nuances in the evidence.
Okay, let's quickly micro-recap the literature review for corticosteroids so far. Early studies suggested benefit, often combined with other agents. IT showed promise as salvage therapy after oral failure, Slattery, Spear-Schwartz, though the average salvage gain's clinical significance was debated.
Battaglia's strong RCT supported the combination of IT and oral steroids, showing superior outcomes and recovery odds compared to oral steroids alone. However, other trials and subsequent reviews suggested initial IT might be equivalent to systemic, Sega's review finding combo controversial, Spear-Schwartz finding initial IT equivalent.
Given the potential for salvage and this IT versus systemic discussion, what's the typical recovery rate after someone has already failed systemic therapy? And what are the specific advantages and disadvantages of going the IT route?
Well, the source notes that the reported recovery rate for ISSNHL after failed previous systemic steroid therapy is generally poorer, maybe around 30–60%, which is in the range of spontaneous recovery itself. This lower success rate after initial systemic failure really supports the rationale for trying salvage therapy options like IT.
Okay, that makes sense. And the key advantage of IT steroid therapy over systemic?
The primary advantage highlighted is achieving much higher steroid concentrations directly in the perilymph, that fluid bathing the inner ear structures.
How much higher are we talking? Is it a significant difference?
Yes. IT delivery results in significantly increased intracochlear steroid concentrations compared to systemic therapy. The source emphasizes that IT administration achieves much higher perilymphatic concentrations than oral therapy can safely provide systemically. There's a substantial concentration gradient across the round window membrane when you apply it topically. This targeted high-dose delivery is thought to contribute to the higher recovery rates, sometimes reported as 50–80%, seen with IT in some studies. You can imagine getting the drug precisely where it needs to act at therapeutic levels you just couldn't reach safely through the whole body.
Right, targeted delivery. And another big advantage of IT is avoiding the systemic side effects, presumably.
Exactly. It reduces the incidence of possible toxic systemic side effects compared to systemic regimens, which is a major consideration for many patients.
Was there a specific study mentioned that looked at IT salvage after IV steroid failure, not just oral?
Yes, the 2012 study by Ferry and coworkers used IT methylprednisolone as salvage therapy, specifically in patients who had failed 10 days of intravenous steroid therapy. They administered IT injections up to 7 times over a 20-day period. And in this group, 52.7% of patients achieved salvage recovery.
Over half recovered, even after IV failure. That's interesting. What factors predicted success in that IT salvage study? Who did best?
The factors significantly influencing hearing recovery in the Ferry study were initiating IT therapy early, having baseline hearing losses less than 80 decibels, so more moderate or less severe loss to begin with, and having involvement of low-frequency deficits on the audiogram. These could potentially serve as clinical predictors for which patients might respond best to IT salvage after failing systemic treatment.
Let's quickly recap IT advantages and salvage outcomes. IT offers higher local concentration in the perilymph and fewer systemic side effects, making it attractive, especially for salvage after systemic failure where reported recovery rates are generally poorer. The Ferry study showed over 50% salvage recovery with IT even after IV failure, with better outcomes seen in those treated early, with less severe initial loss, and with low-frequency deficits.
Now let's balance that by discussing the disadvantages and side effects of both systemic and IT steroids. What are the potential issues clinicians and patients need to be aware of with systemic steroid therapy?
While systemic steroid side effects can be significant, as many clinicians know, they include things like hyperglycemia or raising blood sugar, which is a big issue for diabetics, hypertension, gastrointestinal bleeding, cataracts with longer use, adrenal suppression, psychosis in rare cases, immunosuppression making infections more likely, and altered mental status. It's a fairly long list of potentials.
But it's important to qualify this for the typical ISSNHL scenario, right?
Yes, absolutely. The source makes a point of noting a paucity of data, meaning a lack of good data, regarding the actual prevalence of these specific side effects when using the relatively short courses of systemic steroids typically prescribed for ISSNHL, like a 2-3 week taper. So while the potential exists, the actual risk with a short course might be lower than with long-term steroid use, but the data specifically for this context isn't robust.
Okay. What about disadvantages or side effects specifically related to the IT administration procedure itself?
Well, IT administration is an injection through the eardrum, so there's potential for pain during the procedure. There's a risk of causing a tympanic membrane perforation, though these often heal. Otitis media or middle ear infection is another possibility. And temporary vertigo is sometimes reported. Hearing loss from the procedure itself is less common, but is a potential risk.
Considering these different side effect profiles, for which patients might IT steroids be a more suitable option, either initially or as salvage therapy?
IT corticosteroids seem like a better option, according to the source, for patients who have contraindications to systemic steroids or those who are intolerant or simply refuse systemic therapy. This includes individuals with conditions like diabetes mellitus, where blood sugar control is vital, immunosuppressed states, where systemic steroids could be dangerous, or a history of peptic ulcer disease, where GI bleeding is a concern. IT avoids those systemic risks. Let's recap side effects and patient selection for IT. Systemic steroids have a list of potential risks, but data on their frequency with the short courses used in ISSNHL is limited. IT administration has its own localized risks like pain, perforation, temporary vertigo. IT is clearly a good option, maybe even preferred for patients with systemic contraindications like diabetes, immunosuppression, or peptic ulcer disease.
Looking now at more recent meta-analyses trying to synthesize this evidence, what did the 2014 Gao and Liu meta-analysis find about the combined use of IT and systemic corticosteroids? This meta-analysis found that combination steroid therapy provides greater benefit than systemic steroid administration alone. And importantly, they also concluded that those patients with severe profound ISSNHL would benefit more with combination therapy than patients with mild-moderate loss based on hearing outcomes. This is a key finding suggesting combination therapy is particularly valuable for the more severe presentations.
Okay, combination better than systemic alone, especially for severe loss. And how did the 2016 Shang et al. Meta-analysis comparing systemic versus IT as initial therapy weigh in? Did it agree?
This meta-analysis looked at 6 randomized controlled trials and came to a slightly different conclusion. They concluded that the IT steroid groups exhibited better outcomes in both pure tone average improvement and overall recovery rate compared to systemic steroid therapy when used as initial treatment. This actually conflicts with those earlier suggestions of equivalence and positions IT as potentially superior even for initial therapy.
Wow, okay. Did that meta-analysis find IT better across all severities?
Sure.
Or just certain groups?
Yes, Ching et al. Concluded that IT corticosteroids might be potentially more beneficial for ISSHL patients regardless of their initial hearing loss severity. This slightly contrasts with Gao and Liu's finding that combination particularly benefited severe loss, but both meta-analyses point towards a strong role for IT either alone or in combination.
And what advantages of IT did Chang et al. List to support their conclusion?
They highlighted several practical points. Assured compliance, since it's administered in office, therapy directed specifically to the affected ear, achieving high concentrations, fewer side effects compared to systemic, being an office-based procedure usually not requiring anesthesia, being generally well tolerated, and its suitability for those with contraindications to systemic steroids.
Okay, final micro recap on these meta-analyses. Gao and Liu supported combination IT plus systemic as better than systemic alone, especially for severe loss. Chang et al. Went further, suggesting initial IT might actually be superior to systemic across all severities, and listed IT's numerous advantages. These analyses seem to lean towards combination and later IT having strong evidence for benefit. Let's try to put together our mega recap for Section 4 on corticosteroids now. The rationale for their use is multi-layered, involving anti-inflammation, acting on TNF-B, potential positive vascular effects, improving blood flow, and affecting electrolyte balance in the crucial vascular fistria.
Clinical evidence generally supports benefit. We saw studies showing IT salvage efficacy after systemic failure. Some reviews suggested initial IT might be equivalent to systemic, but the strong Battaglia RCT and meta-analyses like Gao and Liu supported the combination of systemic and IT, particularly for severe loss. Kang et al.'s meta-analysis even suggested IT might be superior as initial therapy.
We discussed the advantages of IT, primarily higher local concentration in the paralymph and fewer systemic side effects balanced against its localized disadvantages or risks. And we identified patients with systemic contraindications like diabetes or PUD for whom IT is clearly preferred.
So, despite some varying findings in different reviews and the ongoing discussion about the optimal delivery method and the role of combination, the evidence presented in the source material firmly establishes corticosteroids as a cornerstone, a fundamental part of ISSNHL treatment strategy.
Absolutely. And now let's turn our attention to the other key therapy highlighted by the source. Hyperbaric Oxygen Therapy. Section 5. Rationale and literature review for HbO2 therapy.
Okay, HbO2. The rationale for using hyperbaric oxygen in ISSNHL is really rooted in the unique metabolic demands and the rather limited vascular structure of the inner ear. Key structures like the stria vascularis and the organ of Corti have very high oxygen requirements to function.
But they don't have a great direct blood supply feeding them that oxygen, right?
That's exactly right. The source notes that the direct vascular supply to the organ of Corti itself is minimal. So tissue oxygenation largely depends on oxygen diffusing from nearby capillary networks into the fluids surrounding these cells, the paralymph and the cortilymph.
So the paralymph is key for oxygen delivery. Have oxygen levels in the paralymph actually been measured in patients with ISSNHL? Is there evidence of hypoxia?
Yes, there is some evidence. A 1983 study by Nagahara and colleagues measured paralymph PO2 in patients with various types of hearing loss. They found that paralymph PO2 tended to be lower in those with ISSHL compared to those with otosclerosis or other types of hearing loss. Now, they didn't find a correlation between the PO2 level and the degree of hearing loss, but this finding led them to suggest that some cases of ISSHL may be due to ischemia or lack of oxygen supply.
Okay, so that provides some early clinical evidence linking low oxygen to the condition itself. How does HbO2 impact those paralymph oxygen levels? Does it make a difference?
This is where HbO2's rationale becomes really compelling. Later studies confirmed that just breathing 100% oxygen at normal atmospheric pressure increases paralymph PO2 about 3.4-fold. But breathing 100% oxygen under hyperbaric conditions, that's HbO2, increases paralymph PO2 dramatically by about 9.4-fold.
Wow, nearly a 10-fold increase in oxygen diffusing into the inner ear fluid.
Yeah.
That seems like a very powerful way to address potential ischemia or hypoxia.
It's a significant physiological effect, yeah.
Yeah.
You're essentially supersaturating the paralymph with oxygen, allowing it to diffuse further and reach tissues that might have compromised blood supply. And beyond just delivering more oxygen, other potential benefits of HbO2 mentioned include alleviating ischemic reperfusion injury, reducing edema or swelling, and having anti-inflammatory effects.
So HbO2 potentially has multiple mechanisms of action, all stemming from dramatically increasing oxygen delivery and maybe modulating the consequences of ischemia in the inner ear.
Correct. It's a direct physiological approach to addressing a suspected ischemic or hypoxic component in ISSNHL.
Let's look at the clinical literature review for HbO2 now, section 5.2. The source notes that HbO2 is often studied as an adjunctive or salvage therapy, but some studies did look at it as a primary treatment.
Right, section 5.2.1 covers HbO2 as a primary treatment. A 1998 randomized controlled trial by Schwab and colleagues evaluated HbO2 as primary treatment. They treated 75 ISSHL patients within 14 days of onset. One group got HbO2 plus their medical therapy, the other got medical therapy alone. The HbO2 group showed statistically significant improvement of 15.6 dB gain compared to the control group's 10.7 dB gain. This supported HbO2's role as part of the initial treatment plan.
Okay, so one positive RCT. What else?
A 2001 RCT by Fattori et al. Compared primary HbO2 directly to intravenous medical therapy in 50 patients who presented very early, within 48 hours. The HbO2 group had significantly greater hearing improvement, a massive 61.3 dB gain versus only 24.0 dB gain in the medical therapy group. They also had a higher response rate, 73% versus 55%. This study strongly favored HbO2 over the medical therapy used.
And didn't that study specifically note benefit for more severe hearing loss?
Yes, that's an interesting point. Fattori et al. Found that patients with pantonal hypoacusis, meaning more severe, broad-frequency hearing loss, responded significantly better to HbO2. This suggests HbO2 might be particularly effective for more severe presentations, which actually contrasts with some findings for other therapies where severe loss is often seen as a negative prognostic factor.
Interesting. Any other primary treatment studies?
A 2003 RCT by Resick and colleagues combined HbO2 with varying doses of IV pentoxifylline and compared it to pentoxifyl alone in 64 patients. Again, the HbO2 group showed statistically significant improvement, 46.35 dB gain versus 21.48 dB. They also had a much higher rate of achieving physiological hearing values, meaning near normal recovery 47.1% versus only 6.2%. This strongly supported HbO2's efficacy, even when combined with another active agent. And finally, a 2007 prospective study by Dundar et al. Compared patients treated primarily with HbO2 versus medical therapy. They found statistically significant hearing gains across all frequencies in the HbO2-treated patients, and also noted that tinnitus improvement seemed to correlate with the degree of hearing improvement.
Right. So multiple studies, including RCTs, are showing significant benefit for HbO2 when used as primary treatment, often compared favorably to medical therapy alone. And some suggest it might be particularly good for more severe initial hearing loss.
That's a key finding from this section, yes. Now, what about HbO2 as a salvage therapy, section 5.2.2? The source states that a significant number of patients, maybe 35–39%, don't respond adequately to initial medical therapy or placebo, and these patients may benefit from salvage HbO2.
Okay, so what's the evidence for using HbO2 after initial medical treatment has failed?
The 1995 RCT by Hoffman and coworkers specifically looked at this. They used HbO2 as salvage therapy in patients who had failed an initial medical regimen, a combination of hydroxyethyl starch, pentoxifylline, and cortisone, about 14 days prior. The HbO2 salvage resulted in significant hearing gains, 7.5 dBbits, compared to basically no gain, 0.7 dB, in the control group who had also failed the initial medical therapy but didn't get salvage HbO2. This showed that adding HbO2 after failure could indeed provide additional measurable benefit.
Does the timing of that salvage HbO2 matter? Is it better to start sooner rather than later?
Absolutely. This is a critical point that comes up repeatedly. A 1998 subset analysis by Lamb and colleagues, looking at over 50 trials involving over 4,000 patients who failed medical therapy, showed a very strong correlation between the time to initiating HbO2 and the outcome. They found 50% had marked hearing gains, defined as 30 dBb, if treated within 2 weeks of onset. This dropped to 33%, having moderate gains, 10–20 dBs, if treated between 2 to 6 weeks. And only about 13% showed definite improvement if treatment was delayed beyond 6 weeks or 3 months. This is powerful evidence supporting early initiation of salvage HbO2.
Okay, so sooner is definitely better.
It seems so. A 2000 retrospective study by Marchesi et al. Of 95 patients unresponsive to medical therapy also reinforced this. They found 78.9% had a mean improvement of 38.3 dB with salvage HbO2, and that HbO2 was most effective in those treated within 14 days.
So earlier is better applies strongly even in the salvage setting. Are there other prognostic factors identified for salvage success with HbO2 besides timing?
Yes. A 2004 review by Murakawa et al. Looked at 522 cases treated with salvage HbO2 after failing medical therapies. They found complete recovery in 34.9% and significant improvement in 23.2%. They identified several prognostic factors associated with a poor outcome: delayed treatment, again 14 days, advanced age, and the presence of vertigo.
Advanced age as a poor prognostic factor in that study. Didn't another study find something different?
Yes, you're right to point that out. It highlights an area where findings might not be entirely consistent regarding age. A 2010 study by Muzzy et al., involving 19 patients receiving HbO2 salvage, found improved BTAs, especially at low frequencies, but noted better results with early HbO2 and in older patients. This conflicts with Murakawa's finding regarding age. So the role of age might be more nuanced or depend on other factors.
Okay. Any other salvage studies?
A 2011 study by Ono et al. Compared ISSHL patients failing medical therapy treated with HbO2 salvage to a similar group treated with medical therapy alone. Interestingly, the overall mean hearing gains were not significantly different between the groups in this study. However, a key finding was that patients with profound hearing loss did show significantly higher hearing gains with HbO2 salvage. This suggests HbO2 salvage might be particularly beneficial for the most severe cases, even if the average benefit across all severities wasn't significant in that specific study.
That's an important nuance. What do the official guidelines say about the salvage window for HbO2? We heard 14 days is best from studies, but what's the guideline stance?
The 2012 American Academy of Otolaryngology Head and Neck Surgery Foundation, or AAO-HNSF, clinical practice guidelines recommended HbO2 therapy for use within 3 months of symptom onset. So while the studies strongly support initiating within 14 days for optimal outcomes, the guidelines offer a much wider window for consideration, perhaps acknowledging that some benefit might still be possible later on.
Let's quickly recap HbO2 as salvage therapy then. Evidence suggests it provides benefit after medical failure. Hoffman, Marchesi, and Murakawa. Timing is critical, with studies showing much better outcomes if initiated within 14 days. Lamb, Marchesi. Though AAO-HNSF guidelines allow consideration up to 3 months. Prognostic factors include delay, possibly age, with conflicting findings, and vertigo. Oh No study suggested specific benefit for profound loss in the salvage setting.
Right. So pulling everything together on HBO2 from Section 5, the rationale is strong, based on dramatically increasing perilymph oxygen levels via diffusion to combat potential ischemia, and this is supported by Nagahara's finding of lower perilymph PO2 in some ISSNHL cases.
Multiple studies support HBO2's efficacy as primary treatment, often showing significant hearing gains compared to medical therapy or control, and some suggesting particular benefit for severe loss, like Fattori, Rachich.
And evidence also supports HBO2 as salvage therapy after medical failure. The timing of initiation is crucial for maximizing outcomes, with strong evidence pointing to treatment within 14 days, although professional guidelines suggest a longer window of up to 3 months is acceptable for consideration.
Overall, the evidence for HBO2 presented in the source, across both primary and salvage settings, consistently points toward a statistically significant benefit for hearing improvement in ISSNHL.
And what about combining HBO2 with those various medical therapies we listed earlier? That seems like a logical next step. Section 6, the use of HBO2 with medical therapies in treatment.
Right, combining HBO2 with other medical therapies. The source says this approach has been extensively investigated, building on the idea that maybe hitting multiple potential pathways at once might be more effective.
Exactly. Let's look at some of these combination studies mentioned. An early one, the 1979 Geiger Perspective, randomized trial, combined HBO2 with either carbogen inhalation or an IV infusion of papaverine and dextran.
What did Geiger find?
Well, initially they found no immediate differences on audiogram testing at 1 year. But a subsequent retrospective analysis suggested statistically better audiometric testing in those treated with carbogen, hinting that hyperoxygenation might improve outcomes even if the initial prospective result wasn't significant.
A bit ambiguous then. What about combining with stellate ganglion block?
A 1987 study by Goto and coworkers compared medical therapy alone, stellate ganglion block, SGB alone, and SGB combined with HBO2. They found that 100% of patients treated with a combination of SGB and HBO2 achieved more than 10 dB PTA improvement, and 40% of these recovered to within 20 dBs of their baseline hearing. That suggests a pretty high response rate with that specific combination.
Okay. And the 1985 Pilgrim study, they combined HBO2 with a specific medical cocktail, right?
Yes, Pilgrim et al. Conducted an RCT in patients treated within 14 days. One group received a specific medical therapy, 500 milliliters of 10% dextran 40 and sorbitol 5%, plus 600 milligram naphthofuryl hydrogen oxalate and vitamin B orally for 14 days. Quite a mix. The other group received that same medical therapy plus 10 sessions of HBO2.
And did adding HBO2 help?
Yes. The HBO2 group had significantly increased hearing gains compared to the medical therapy only group, 29.2 dB versus 20.2 dB. This provided support for the benefit of adding HBO2 to that particular medical regimen. Then a 1993 investigation by French investigators reviewed several studies evaluating HBO2 combined with various medical therapies. They found HBO2 to be a useful synergistic adjunct. They also noted that using twice-daily HBO2 sessions could potentially reduce the overall length of therapy, which is a practical point about protocol optimization.
Now, the source specifically highlights the 1996 RCT by Cavalazzi et al., as often cited, but having significant limitations. This study compared medical therapy with or without HBO2. What was the issue here?
Yes. In this study of 64 patients, the addition of HBO2 did not result in statistically significant improvement in hearing compared to the control group, although a numerically higher percentage showed improvement, 95% versus 71% recovered to within 20 dBs. However, the source details substantial limitations for this study that make its findings very difficult to interpret, maybe even invalid.
What were those key limitations again? It sounds important if this study is often cited.
Crucially, the authors did not report the duration of hearing loss for the study groups, so the acuity or chronicity is unknown. The medical therapy involved a multitude of drugs, 10 different ones, including heparin, steroids, vitamins, antivirals, etc., but the doses were not provided. These factors make the study virtually impossible to replicate or validate, a basic requirement of science. Additionally, the source notes possible selection bias, no mention of allocation concealment. It wasn't blinded, randomization wasn't clearly described, just numerous flaws.
Okay, so the non-significant finding in Cavalazzi needs to be viewed with extreme caution, perhaps even disregarded, due to these serious methodological flaws.
Absolutely. That's the strong message from the source.
Yeah.
In contrast, a 2002 study by Aslan et al., utilizing medical therapy combined with either SGB or HBO2, did find a significant increase in hearing gains with the addition of HBO2 therapy, supporting a synergistic effect.
And then there's the 2004 RCT by Topuz and others, which seemed quite positive for combination.
Yes, the TOPUS study is presented as a strong one supporting combination therapy. They studied 51 ISSHL patients treated within 2 weeks. The medical therapy was quite specific: 4-ibuprofene, arbitrio macrodex, dextrin, oral diazepam, IV pentoxifylline, and salt restriction. One group got this, the other got this, plus 25 sessions of HBO2 using an aggressive initial twice-daily protocol.
What did Topaz et al. Find about adding HBO2 to that multi-drug regimen?
The findings were very positive and quite detailed. For patients with mild or moderate hearing loss, adding HBO2 significantly improved hearing gains, 35.4 dB versus 16.2 dBs. But for those with severe hearing loss, the statistically superior results for the HBO2 group were even more impressive, a gain of 50.7 dB versus only 13 dB in the medical therapy-only group. This provides strong quantitative evidence for combination benefit across severities, but particularly pronounced for severe loss.
Any other key findings from Topaz?
The HBO2 group displayed statistically significant improvement in hearing gains over all frequencies tested, except for 2 kHz. And interestingly, they found that within the HBO2 group, the mean hearing gains for those older than 50 years was actually greater than for those younger than 50. This contrasts with some other studies suggesting advanced age is a poor prognostic factor, like Morikawa and Muzzi's finding too. So age remains a complex factor.
Okay. What about reviews looking at combination therapies?
A 2006 review by Narozny et al. Looked at 2 historical groups treated with combinations of medical therapy, corticosteroids, and HBO2. They found hearing gains were statistically significant for the HBO2 group over all frequencies. They concluded specifically that the combination of corticosteroids and HBO2 resulted in statistically improved clinical outcomes.
Did Narozny identify prognostic factors for combination therapy?
Yes. Based on linear regression analysis, they identified delay to treatment and a flat audiogram configuration as factors associated with poor outcomes. Conversely, factors predicting favorable outcomes were treatment with high-dose corticosteroids plus HBO2 and early treatment within 10 days. This provides strong support for early combination therapy involving steroids and HBO2. They also mentioned labyrinth responsiveness disorders and decreased TSH levels as other poor prognostic factors.
So that review reinforces both the specific steroid plus HBO2 combination and early treatment. What about combining HBO2 with agents other than standard steroids? Was that explored?
Yes. A 2008 study by Suzuki and coworkers compared combining HBO2 with either steroids or intravenous prostaglandin E1, PG1, in 196 consecutive patients. They found no differences between the groups, suggesting PGE1 might be equally effective when combined with HBO2, potentially offering an alternative for steroid-intolerant patients in this combination setting.
Interesting. Did Suzuki look at other combinations?
Yes. Another 2008 study by the same lead author compared ISSHL patients treated with IV PGE1 plus HBO2 versus SQB plus HBO2. They found similar outcomes in those with less severe hearing loss, 80 dBs. However, for those with severe hearing loss, 80 dB, the hearing recovery rate was statistically superior in the group treated with SGB and HBO2. This suggests the optimal combination partner for HBO2 might differ based on severity, favoring SGB for profound loss in this study.
Now, there was another study mentioned that didn't find a significant benefit for adding HBO2 to steroids, the 2009 RCT by Sekin et al.
Correct. Sekin et al. Conducted an RCT comparing medical therapy with prednisone, tapering over 3 weeks, with or without HBO2 in 57 patients. They found both groups had fairly high recovery rates, above 70%, but there were no statistical differences between the group getting steroids alone and the group getting steroids plus HBO2.
But were there limitations noted for this study too?
Yes. The source points out a lack of an intention to treat analysis. It also mentions that the lead author, when contacted, stated that some control patients who were not improving did not return for follow-up, which could potentially skew the results, making the control group look better than it was if the non-responders dropped out. So like Cavalazzi, it's a non-significant finding from a study with noted limitations.
Okay. Shifting back to positive findings for combination.
A 2010 review by Liu and others looked at 120 ISSHL patients treated within 2 weeks with medical therapy, with or without HBO2. They found the overall efficacy was clinically and statistically superior for the HBO2 patients. The most profound improvement occurred in those with moderate to severe deafness and those with descending and flat types of audiograms, again suggesting benefit for specific configurations and greater severity.
And a 2011 study by Corpinar looked at prognostic factors within combined medical plus HBO2 therapy.
Yes. Corpiner and coworkers investigated factors affecting outcomes in 80 patients treated with medical therapy and HbO2. Factors significantly improving hearing gains included receiving more HbO2 treatments, the use of corticosteroids as part of the medical therapy, early onset of treatment, having low-frequency ascending or total pantanal audiogram configurations, and having profound hearing loss initially. This provides a useful list of positive prognostic indicators for this combination approach, many aligning with previous findings: early treatment, severity configuration, steroids.
The 2011 Holy study also emphasized timing.
Yes. Holy and colleagues evaluated outcomes of 61 patients treated with IV vasodilatation therapy and HbO2. Hearing improvement occurred in nearly 60%, but the timing effect was stark. If HbO2 was started within 10 days, significant or complete recovery occurred in 65.9%. If HbO2 was started more than 10 days from symptom onset, improvement was noted in only 38.9%. This again strongly reinforced the importance of early initiation of combination therapy involving HbO2.
And finally, another 2011 retrospective review by Liu et al. Looked at different combinations involving steroids, dextrin, and HbO2.
Right. This review of 465 patients compared IV or oral corticosteroids alone, steroids plus dextrin, or steroids plus dextrin plus HbO2. They found the addition of HbO2 was beneficial, specifically in those with initially profound hearing loss. Interestingly, the addition of dextrin did not appear to improve outcomes. This study specifically points to HbO2 when combined with steroids being the key driver of benefit in severe cases, not necessarily the dextrin component.
Wow, that's a lot of data on various combinations. Let's try a comprehensive micro recap of Section 6 on HbO2 combined with medical therapies.
Okay, deep breath. We saw early studies suggesting benefit, Jarger retrospectively, GO2 with SGB. Pilgrim showed benefit adding HbO2 to a specific medical cocktail. A French review found it synergistic and suggested twice-daily protocols. The Cavalazzi study, often cited as negative, was noted to have severe limitations.
Right. Then Aslan found benefit adding HbO2 or SGB to medical therapy. Topaz showed strong benefit for adding HbO2 to a prednisone-based regimen across severities, particularly impressive for severe loss, and had that interesting finding about older patients doing better. Narozny's review explicitly supported the corticosteroid plus HbO2 combination and identified key prognostic factors like early treatment.
Suzuki's studies suggested PGE1 might be an alternative to steroids when combined with HbO2, and that SGB plus HbO2 might be superior for severe loss compared to PGE1 plus HbO2. Sakin's study failed to show significant benefit for adding HbO2 to prednisone, but again, had limitations noted.
Liu's 2010 review found overall benefit for adding HbO2, especially for moderate severe loss in certain audiograms. Corpinar identified positive prognostic factors for medical plus HbO2 combo, including more HbO2 sessions, steroids, early onset, and profound loss. Holy strongly reinforced early 10 days initiation for vasodilators plus HbO2, and Liu's 2011 review highlighted HbO2's benefit in profound loss when combined with steroids, suggesting dextrin didn't add value.
Phew. Okay, so the overall picture from this section is that studies evaluating HbO2 combined with various medical therapies frequently show significant benefit when HbO2 is added, particularly for more severe hearing loss and when initiated early. While a couple of the studies fail to show significance, the source emphasizes methodological limitations in those cases.
The evidence presented across multiple studies seems to support a synergistic effect, with several identifying early treatment and severity or specific audiogram configurations as predictors of better outcomes with combination therapy.
And that leads us directly to the specific combination the source says has the best evidence overall, focusing just on HbO2 with corticosteroids in Section 7.
Right, Section 7, the use of HbO2 with corticosteroids in the treatment of ISSHL. This is where the source says the evidence for improvement is strongest. Let's look at studies focusing specifically on this combination.
Okay. The 2007 study by Fujimura and colleagues compared corticosteroids alone versus corticosteroids combined with HbO2 in 130 consecutive ISSHL patients. What did they find?
They found the group receiving HbO2 in addition to corticosteroids showed a statistically improved rate of hearing recovery overall. And in a subset analysis looking only at patients with severe loss, greater than 80 dB, the HbO2 group also had a statistically superior rate of hearing recovery. This again points clearly to the benefit of adding HbO2 to steroids, especially for those with severe cases.
Was there a study looking specifically at predictors of success within this particular steroid plus HbO2 combination?
Yes, a 2011 simple and multiple regression analysis by Suzuki and colleagues looked at 174 consecutive patients treated with hydrocortisone and HbO2. Their goal was to develop a model predicting hearing outcomes. They found significant correlations between the amount of hearing improvement and three factors: the number of days from onset to treatment, earlier was better; patient age, younger was better in this study; and the presence of vertigo, absence was better. This helps identify specific prognostic factors when using this combination therapy.
Okay, so early treatment, younger age, no vertigo predict better outcomes with steroid plus HbO2 combo, according to Suzuki. What about the Alamoglu study from 2011? It reviewed different steroid HbO2 combinations.
Alamoglu et al.'s retrospective review looked at 217 ISSHL patients, actually 219 years, who received various combinations of oral or IT corticosteroids and HbO2. Their key finding was that the most statistically superior hearing gains, the highest mean decibel gain, and the greatest proportion of complete recovery occurred with the use of both oral corticosteroids and HbO2 therapy. This study provides strong evidence directly supporting the specific combination of standard oral steroids plus HbO2.
That seems quite definitive from that review. Now, a 2012 prospective randomized trial by Filippo and colleagues looked at patients with severe or profound loss. They all got HbO2 and IV steroids, but the profound group also received IT steroids. What was the outcome there?
Filippo et al. Reported observing an additional benefit in the rate of improvement in the profound loss group who received the triple therapy, IV steroids plus IT steroids plus HbO2. However, despite this observed trend, the results were not statistically significant. This likely reflects the challenge of showing statistical significance in relatively small studies, only 48 patients total, even if trends appear favorable. It also contrasts a bit with Alamoglu's finding that oral steroids plus HbO2 gave the best results.
Right, statistical power is always an issue in smaller trials. Now, a larger, more recent study mentioned is the 2015 retrospective 4-year cohort study by Capuano and colleagues. They compared 3 groups: 4 steroids alone, IVS, HbO2 alone, and the combination of IVS plus HbO2 with 100 patients in each group.
Yes, this study of 300 patients is quite compelling. Baseline characteristics were similar between the groups. The key finding was the response rate. The IVS plus HbO2 group had the highest response rate overall, 84%, compared to HbO2 alone, 70%, or IVS alone, 68%. But the really dramatic finding was in complete recovery.
What was the complete recovery rate difference?
The combination, IVS plus HbO2 group, had a dramatically higher rate of complete recovery, 58%, compared to just 24% for HbO2 alone, and 20% for IV steroids alone. And this was regardless of the initial hearing levels. Imagine that on a graph, the combination bar for complete recovery is more than double the height of the bars for either therapy alone. That's very strong evidence favoring the combination approach.
That is a striking difference. Did they look at the timing of treatment?
Yes, and consistent with other studies, they found that in all 3 groups, patients who began therapy within the first 2 weeks had significantly greater mean hearing gains. This reinforces the benefit of early treatment across all modalities studied. They also found that patients with hypercholesterolemia, over 240 mg/dL, had significantly worse responses to therapy.
That reinforces the link between those cardiovascular risk factors and poor prognosis again. What was the overall conclusion from the Capuano study authors?
The title of their study actually asked if routine application of HbO2 was helpful in ISSHL. Their conclusion was clear. The combination of HbO2 and steroids was more effective than either therapy administered alone. This directly supports the primary recommendation emerging from the source material.
Okay, let's consolidate the evidence specifically for the combination of corticosteroids and HbO2 from Section 7. Studies like Fujimura, Alamoglu, and particularly the large Capuano cohort study strongly support this combination. They show improved recovery rates overall and significantly higher complete recovery rates, Capuano's 58%, compared to either therapy alone, with benefits often noted, especially in severe loss.
Prognostic factors identified within this combination framework often include early treatment, Suzuki Capuano. Age is a bit conflicting. Suzuki found younger better. Topuz found older better in a different combo study. Vertigo absence seems favorable, Suzuki. And hypercholesterolemia seems unfavorable, Capuano.
While small studies didn't always reach statistical significance for additional elements like adding IK steroids to the mix, Filippo, the weight of evidence presented in this section firmly positions the combination of corticosteroids, often systemic oral or IV, and HbO2 as the most supported therapeutic strategy based on the literature reviewed in the source.
It really seems like that's where the evidence for positive outcomes in ISSNHL appears strongest according to our source.
Which brings us neatly to Section 8, Literature Summary for the Treatment of ISSNHL.
which aims to synthesize these points and critically examine the overall quality of the evidence we've just discussed.
Right. Section 8, literature summary. So the source reiterates the main takeaway point first.
Yes, it reiterates that main point. The best evidence regarding improvement in hearing for those with ISSHL involved combination therapy with corticosteroids and HbO2. That's the headline finding from the review of the literature.
The source then refers to a Table 1 summarizing 15 studies. What level of evidence do these studies represent? Are they top-tier RCTs?
No, these 15 trials, which include both retrospective and prospective case-controlled series totaling over 2,300 patients treated with various medical therapies, HbO2 or both, are classified as Class 2 evidence. While Class 1 evidence, large, well-conducted randomized controlled trials is the ideal gold standard, the source notes that these Class 2 trials are generally adequately dosed and treated patients relatively early, within 30 days of symptom onset, making them valuable contributions to our understanding.
And the source makes a point about the practicalities of clinical research, doesn't it? About demanding only Class 1 evidence.
Yes, it reminds us that much of medicine and surgery is actually practiced without Class 1 evidence underpinning every single decision. It cites examples like the ethical barriers to performing sham surgeries or the inherent difficulties of conducting large RCTs for many critical care interventions. This context helps explain why Class 2 evidence is often relied upon for guiding clinical practice in complex areas like ISSNHL, where Class 1 evidence might be scarce or difficult to obtain.
Okay, that's fair context. What about specific critiques of the HbO2 literature's methodology? Does the source highlight any major limitations there?
Yes, a critical limitation highlighted specifically for the HbO2 studies is the absence of a truly convincing sham-controlled protocol. The source states quite unequivocally that the lack of sham controls is a limitation of every single comparative trial in the HbO2 literature discussed in this material. Developing a believable sham control, something that mimics the experience without delivering the hyperbaric oxygen, is seen as a crucial next step for future research to better assess potential placebo effects. You can imagine the logistical challenge of creating a convincing sham HbO2 treatment inside a chamber.
Right. So all the positive HbO2 findings we've discussed, whether primary, salvage, or combination, come with this inherent methodological limitation of not being rigorously sham controlled. That's important to keep in mind.
It is a key critique the source raises. The source then mentions a Table 2, which highlights 8 specific RCTs on HbO2 use, noting some exclusions, including the 1996 Cavallazzi RCT that we discussed earlier, as having non-significant findings and limitations.
And what was the detailed critique for excluding Cavallazzi from potentially stronger consideration?
The critique is quite detailed. Possible selection bias due to lack of information on allocation concealment and unclear randomization procedures. It was unblinded. It lacked sham controls. And critically, it had fatal flaws in excluding key information. The authors didn't report the study group's duration of symptomatology, so acute chronicity is unknown. Plus, the medical therapy involved 10 different drugs, but the doses weren't provided. These omissions make the trial essentially irreplicable and difficult to validate.
Okay, very flawed. The 1995 Hoffman RCT is also critiqued and excluded from strong consideration.
Yes. The Hoffman RCT is critiqued for similar issues, like unclear randomization and allocation concealment and being unblinded. But it also had specific fatal flaws according to the source. First, the omission of standard deviations for the results, which makes proper interpretation of the findings and their statistical significance impossible. Second, and perhaps more importantly from a physiological standpoint, they used hyperbaric air as the control condition, which is not physiologically inert like a true placebo, rather than a proper inactive control group.
And wasn't this Hoffman study looking at chronic ISSNHL, not acute?
Exactly. That's a crucial point. The source makes a very strong statement that it is an error to include this study, which deals with chronic ISSNHL patients treated much later, in meta-analyses that are supposed to be about acute ISSNHL. The patient populations are simply not similar enough. It argues forcefully that continuing to include this specific RCT in meta-analyses of acute ISSNHL should just cease.
Right. So the source provides both the conclusion about the best evidence pointing towards combination therapy and a very critical, detailed look at the methodological challenges and specific flawed studies that sometimes get included in broader analyses, particularly when evaluating HbO2.
Precisely. It highlights the need for careful, critical interpretation of the literature. We should recognize the strengths of consistent findings across multiple, reasonably well-conducted Class 2 studies supporting combination therapy, while simultaneously acknowledging the limitations, like the absence of sham controls for HbO2 and the need to firmly exclude methodologically flawed or irrelevant studies, like Hoffman's chronic trial, from meta-analyses focusing on acute ISSNHL.
Okay, let's quickly recap Section 8's literature summary. The best evidence for hearing improvement in ISSNHL points to combination therapy with corticosteroids and HbO2, primarily supported by Class 2 studies.
While Class 1 evidence is the ideal, the source contextualizes the reliance on Class 2 evidence due to the practical realities of clinical research in this area. A critical methodological limitation across all discussed HbO2 comparative trials is the lack of convincing sham controls.
The source provides detailed critiques of specific methodologically flawed RCTs like Cavalazzi and Hoffman, arguing strongly against, including studies like the chronic ISSNHL Hoffman trial in meta-analyses focused on acute ISSNHL due to fundamental issues with patient populations and study design.
So this section really emphasizes the overall strength of the evidence favoring combination therapy while providing crucial caveats about interpreting the broader literature base critically.
And this leads us into Section 9, ISSNHL meta-analyses of treatments, where we see how some of these studies have been synthesized, sometimes with varying and, well, controversial results.
Right, meta-analyses. Few topics in otolaryngology seem to generate as much controversy as ISSNHL treatment. Approaches vary regionally outpatient versus hospital admission, for example. And as we said, over 60 protocols exist with all sorts of variations. Systemic corticosteroids are often considered the gold standard, particularly in North America, although the source qualifies this, acknowledging this is considered by some not universally agreed upon.
Meta-analyses attempt to bring clarity by pooling data. What did the 2008 Collin and Parnes systematic review find when they looked at prospective RCTs for ISSHL treatment?
They reviewed 20 RCTs they identified out of 118 initially screened, covering a wide variety of treatments. Systemic and IT corticosteroids, antivirals, hemodilution agents, minerals, vitamins, herbal stuff, petroxime, carbogen, HbO2, a whole gamut. All studies used audiometric outcomes.
What did they conclude about the validity and results of these RCTs?
Well, they found significant issues. Only 2 studies used identical criteria to define ISSHL. The validity scores for randomization ranged widely. While positive results were reported in individual RCTs for systemic IT corticosteroids, petroxime, magnesium, vitamin E, and HbO2, the authors found serious limitations in every single study they included.
Serious limitations in every RCT. That's a pretty damning assessment of the Class 1 evidence base at that time.
It is. Based on these limitations, they found no differences reported in studies involving antivirals or hemodilution agents versus placebo, concluding there was no valid RCT evidence for effective antiviral treatment. And crucially, given the severe limitations they identified in the landmark studies supporting systemic corticosteroid use, they stated systemic corticosteroids cannot be considered the gold standard.
Wow. So a review focusing only on the RCT evidence available then questioned the standard treatment. How does the source view that conclusion?
The source critiques this Collin and Parnes review specifically for failing to consider the substantial amount of Class 2 evidence supporting corticosteroid use, which we discussed earlier. It suggests that focusing only on the flawed RCTs might give an incomplete picture.
Okay. What about the well-known Cochrane reviews? Did the 2009 Cochrane review by Agarwal and Pathir find more clarity on specific therapies?
That review looked at various therapies. Regarding HbO2 specifically, the source notes that Agarwal and Pathir could apparently only find one RCT for inclusion in their review focusing on vasoactive therapies, which seems surprising given the studies we've already discussed. This leads the source to reference the 2008 Cochrane review focused specifically on HbO2, which was done by Murphy and Lamp.
Ah, okay.
Well,
So what did the 2008 HbO2 specific Cochrane review find?
This review analyzed 6 trials with 308 patients and was distinctly positive. It concluded that the use of HbO2 imparts a statistically significant mean improvement over controls at all frequencies tested. It also confirmed that people who presented early for treatment significantly improved their hearing loss.
So that Cochrane review was positive for HbO2. Despite this, the source still notes a general gap in evidence synthesis overall.
Yes, the source laments quite strongly that unfortunately none of the existing meta-analyses thoroughly evaluates all of the published RCTs and the Class 2 evidence regarding the treatment of acute ISSHL. This highlights that even with dedicated meta-analyses, fully capturing the complex evidence base, including different levels of evidence, remains a significant challenge in this field.
Let's quickly recap the Conlin-Parnes review and the initial Cochrane perspective described. Conlin-Parnes found serious limitations in all included RCTs, questioned systemic steroids as gold standard based on that limited RCT view, and found no evidence for antiviral hemodilution but was critiqued for ignoring Class 2 evidence. The 2008 HBO2 specific Cochrane review, Murphy Lamp, was positive, finding significant benefit, especially with early presentations standing out. But a truly comprehensive meta-analysis of all evidence is still lacking according to the source.
Now let's look at some other specific Cochrane reviews for different therapy categories mentioned in the source. What about the 2009 Cochrane review on vasodilators and vasoactive agents? This review, also by Agrawal and Pothier, evaluated the use of vasodilators and vasoactive substances. They looked at 3 trials with 189 patients. Their finding was that the effectiveness of these agents in ISSHL remains unproven due to the small numbers of patients studied and significant heterogeneities regarding the type of drug, dosage, and duration of therapy used across the trials. They couldn't combine the results to reach a firm conclusion. So essentially a negative or inconclusive finding for this class of drugs based on this review.
Okay, vasodilators unproven. And the 2012 Cochrane review on antivirals. Any clearer there?
This review, by Awad and colleagues, evaluated RCTs comparing different antivirals versus placebo, sometimes with other treatments involved. They included 4 RCTs with 257 patients. They found the trials generally had a low risk of bias and no serious adverse effects related to antiviral treatment were found. However, the main finding was that there was no statistically significant advantage detected in the use of antivirals for treating ISSNHL. So, another clear negative finding for antivirals based on this Cochrane review.
Okay, no benefit shown for antivirals. What about the Cochrane reviews on the cornerstone therapy, corticosteroids? The 2006 review by Weir et al.?
The initial 2006 Cochrane review looked at 2 studies involving patients receiving oral corticosteroids. They found conflicting results. One study showed a significant improvement in hearing, 61% improved versus 32% in control, but the other study showed a lack of effect. Based on this, their conclusion was that the value of corticosteroids remains unclear.
Only 2 studies and conflicting results. What about the 2013 update of that review? Did adding more data help?
The 2013 update added 1 more study, bringing the total to 3 studies with 267 patients evaluated. However, that 3rd study also showed a lack of effect compared to placebo, and the reviewers noted it was hindered by strict inclusion criteria, significant exclusion of patients, and issues with patient compliance. So the overall conclusion remained the same in the 2013 update. The value of corticosteroids remains unclear due to contradictory results and the small number of patients included in the RCTs they reviewed. This conclusion seems surprisingly weak given the other literature we've discussed supporting steroids, especially in combination.
Yeah, that does seem inconsistent with the broader picture presented. What about the 2014 Cochrane review looking specifically at intratympanic corticosteroids?
This review, by Planta and others, concluded that IT steroid treatment is equivalent to systemic corticosteroids and is of unclear clinical significance. Again, this conclusion regarding unclear clinical significance seems to conflict with findings from individual studies and meta-analyses like Kang et al., which suggested IT might even be superior or at least offer advantages for certain patients. It highlights potential discrepancies between different evidence syntheses.
Right, so these specific Cochrane reviews cited for vasodilators, antivirals, and corticosteroids, both systemic and IT, are largely negative or inconclusive based on the specific RCTs they included.
That's correct. However, the source then makes a very strong comparative statement about the HBO2 Cochrane reviews. It states that the only Cochrane reviews regarding ISSNHL treatment that show significant benefit of therapy are the meta-analyses involving the use of HBO2. This really positions the HBO2 evidence favorably within the context of these specific Cochrane reviews cited in the source. The 2005 Cochrane review on HBO2 by Bennett and colleagues, reviewing 6 trials, confirmed that HBO2 did improve hearing.
And the 2007 update of that HBO2 review provided more quantitative detail on the benefit.
Yes, exactly. The 2007 update, by the same authors, analyzed 6 trials with 308 patients. They again found that the use of HBO2 imparts a statistically significant mean improvement over controls at all frequencies, and they quantified the improvement. An average of 37.7 dB improvement for those starting with severe loss, 19.3 dB for those with moderate loss, and 15.6 dB of hearing improvement overall across all patients. These are pretty concrete numbers showing substantial gains, especially for severe loss.
And they confirm the importance of timing again.
Yes, they confirmed a significantly improved hearing loss with early presentation of ISSHL, and they calculated that crucial number needed to treat the NNT.
What was the NNT for HBO2?
The update highlighted the NNT for one extra good outcome, hearing improvement, was 5.3. The source makes a powerful comparison here, noting that this NNT correlates well with the NNT reported for treating diabetic foot wounds with HBO2, which is around 4, also considered effective. And perhaps more strikingly, it states this NNT of 5.3 is superior to any NNT found on the NNT website, giving the URL http://home-n/NNT, with the sole exception of using defibrillation for cardiac arrest.
Wow. Comparing it to defibrillation really puts that NNT into perspective regarding relative efficacy, at least based on that metric.
It's a compelling statistic arguing for its clinical utility when effective. And importantly, subsequent Cochrane reviews on HbO2 in 2010 and 2012, which analyzed 7 trials with 392 patients, reportedly reached the same objective and positive conclusions. This confirms the robustness of the earlier positive findings for HbO2 within the Cochrane review framework, at least as presented by the source.
Okay, let's bring together the mega recap for Section 9 on meta-analyses. We started with the Conlin and Parnes systematic review, which highlighted serious limitations in all included RCTs and questioned systemic steroids based solely on that limited RCT view, while being critiqued for ignoring Class 2 evidence.
Cochrane reviews for vasodilators, the vasoactives, and antivirals were largely negative or inconclusive due to limited or negative evidence from the included trials.
The Cochrane reviews specifically for corticosteroids were also surprisingly inconclusive across different versions, 2006-2013 update, and for IT delivery 2014, citing conflicting results and methodological issues. This seems somewhat at odds with findings from other literature and meta-analyses suggesting stronger benefits, particularly for combination therapy.
In stark contrast, the Cochrane reviews, specifically on HbO2 2005, 2007, 2010, 2012, consistently found a statistically significant benefit. The 2007 update provided specific quantitative improvements by severity level, conferred the early treatment benefit, and highlighted a notably favorable NNT of 5.3, comparing it positively to other common medical interventions based on the NNT website data.
So while meta-analyses present a mixed or inconclusive picture for other therapies based on the specific Cochrane reviews cited, those reviews are presented as consistently positive specifically for HbO2. However, we have to remember the source's earlier point about the lack of a truly comprehensive meta-analysis combining all Class 1 and Class 2 evidence for acute ISSNHL, and the methodological critiques like lack of sham controls for HbO2.
Absolutely, that context is vital. Based on this complex evidence landscape, who are the right patients to consider for these therapies, particularly HbO2, where timing and severity seem important? Let's look at Section 10, Patient Selection Criteria.
Right, Section 10, Patient Selection Criteria. Identifying the individuals most likely to benefit seems crucial, especially for a therapy like HbO2, which involves multiple sessions. What do the guidelines or expert bodies suggest?
The Undersea and Hyperbaric Medical Society, or UHMS, committee report provides specific recommendations for HbO2 consideration.
And what does the UHMS report suggest? Who should consider HbO2?
The UHMS report advocates for patients with moderate to profound ISSHL loss. They define this as greater than 40 decibels of loss who present within 14 days of symptom onset. So they specify both a severity threshold and a relatively narrow time window for optimal consideration.
Within 14 days. But we saw some studies suggesting benefit might still occur later than that, didn't we?
Yes, the source acknowledges this, noting contrasting literature that shows patients presenting later than 14 days may still show some improvement with HbO2. This suggests the 14-day window might be ideal for the best chance of significant recovery, but perhaps not an absolute rigid cutoff where no benefit is possible later.
What about the American Academy of Otolaryngology Head and Neck Foundation, AAO-HNSF guidelines regarding the time window for HbO2? Do they agree with the 14 days?
No, the AAO-HNSF advocates for considering HbO2 therapy for up to 3 months following symptom onset. This provides guideline support for a significantly longer window for potential treatment initiation. The source notes this specific AAO-HNSF statement is actually referenced as the entirety of the guidelines on HbO2 available on the National Guideline Clearinghouse website, guidelines.gov.
Okay, so we have UHMS suggesting 14 days ideally, but AAO-HNSF allowing up to 3 months. That's quite a difference. What's the consistent principle from the literature, though?
The overwhelming principle supported by most of the medical literature we've discussed is that early intervention is associated with improved outcomes. While delayed treatment might still offer some help, initiating therapy sooner, ideally within the first few days or maybe couple of weeks, seems consistently linked to better results across different studies and therapies.
Does the source give any insight into how HbO2 is actually applied in clinical practice? Are protocols consistent?
It references a 2016 survey by Uzone and colleagues that looked at European hyperbaric centers. A high percentage, 73.3% of the responding centers, were utilizing HbO2 for ISSNHL treatment. Interestingly, their common practice regarding the treatment window was accepting patients if they presented within 30 days of onset, which falls somewhere between the UHMS 14-day suggestion and the AAO-HNSF 3-month guideline.
Were they only treating hearing loss or other related symptoms too?
Approximately 43% of the centers reported they were also treating patients presenting with tinnitus symptoms only, which expands the potential application beyond just measurable hearing loss.
And what about their treatment protocols? Were they standardized?
Not really. The survey found wide variability. The number of treatment sessions ranged anywhere from 5 to 40, with a median of 20. Most centers treated once daily, 76.6%, but nearly a quarter used twice daily sessions, especially initially, perhaps. And the treatment pressure also varied, typically between 1.5 ATA and 2.5 ATA. The survey authors concluded that these wide-ranging approaches clearly illustrate the need for more research to identify an optimal, standardized HbO2 treatment protocol.
Okay, let's quickly recap patient selection criteria, mainly for HbO2. UHMS suggests considering it for moderate profound loss presenting within 14 days. AAO-HNSF guidelines extend that window for consideration up to 3 months, and this is reflected on guidelines.gov. However, most literature strongly supports the critical importance of early intervention for best outcomes, even if later treatment might still offer some benefit.
The European survey shows real-world practice commonly accepts patients within 30 days. It also reveals significant variability in treatment protocols regarding number of sessions, frequency, once versus twice daily, and pressure used. Some centers also treat tinnitus alone. This variability underscores the ongoing need for research to define the optimal protocol for HbO2 in ISSNHL.
Absolutely. Before we delve into the specific management and treatment guidelines based on this evidence, it's vital to remember that ISSNHL is often a diagnosis of exclusion. We have to consider other potential causes first. Section 11, differential diagnosis of acquired sudden deafness.
Yes, this is an absolutely crucial step in managing any patient presenting with suspected SSNHL. While we know about 88% of cases will end up being idiopathic, ruling out the identifiable causes in the remaining 12–15% is essential, as some of those causes require very different management.
What are some of the key categories and specific conditions that must be considered in the differential diagnosis? Where should our minds go initially?
The source provides a pretty detailed list. First, a small but critical group. Approximately 1% of sudden sensorineural hearing loss is due to retrocochlear disease. That means problems behind the cochlea affecting the auditory nerve or brainstem pathways. This includes things like vestibular schwannoma, often called acoustic neuroma, demyelinating diseases like multiple sclerosis, and stroke affecting auditory centers. These absolutely must be ruled out due to their potential severity and need for specific neurological or neurosurgical management.
Okay, rule out retrocochlear first. What other categories of identifiable causes?
Other identifiable causes fall into several broad categories. First, infectious causes. This includes a whole range of conditions like bacterial meningitis, viral infections like mumps, rubella, various herpes viruses like BZV or CMV, syphilis, Lyme's disease, HIV/AIDS, even things like Lassa fever, mononucleosis, mycoplasma, toxoplasmosis. Quite a list.
That's a wide array of infections to potentially screen for, depending on history and risk factors. What about traumatic causes?
Traumatic etiologies involve physical injury or pressure-related events. Things like temporal bone fracture, significant acoustic trauma from sudden loud noise, barotrauma, often from diving or flying, sudden changes in cerebrospinal fluid pressure, perhaps after procedures like a lumbar puncture, and importantly, paralymphatic fistula, which is a leak of inner ear fluid, often post-traumatic or spontaneous.
Okay. And specific vascular causes beyond the general ischemia theories we discussed in idiopathogenesis.
Yes. Vascular etiologies mentioned include specific conditions like sickle cell disease, which can cause microvascular occlusion, issues related to cardiopulmonary bypass surgery, generalized hypoperfusion states like shock, and vertebrobascular insufficiency affecting blood supply to the brainstem and auditory centers.
Neurological conditions besides MS.
Neurological causes listed include stroke, which overlaps with vascular, multiple sclerosis, as mentioned, and neurosarcoidosis, an inflammatory condition that can affect the nervous system.
And neoplasms or tumors, besides acoustic neuroma.
Yes, neoplastic causes include acoustic neuroma again, but also other tumors like lymphoma, meningioma, or systemic malignancies that can involve the ear structures or auditory nerves, such as leukemia, myeloma, meningeal carcinomatosis, or metastatic disease from cancers elsewhere.
Finally, there's that broad category of other causes. What falls in there?
This is a real grab bag covering diverse mechanisms. It includes toxic effects from snake bites or ototoxic drugs like certain antibiotics or chemotherapy agents. Hormonal influences like oral contraceptives have been implicated. Autoimmune diseases like Cogan syndrome or Weisner's granulomatosis, primary autoimmune inner ear disease itself. Structural issues like cochlear membrane rupture, which might overlap with traumatic fistula. Non-organic or functional hearing loss, termed pseudohypoacusis. Conditions related to fluid pressure like hydrops cranialis, intracranial pressure issues, or Meniere's disease, endolymphatic hydrops, and even metabolic derangements or general cochlear dysfunction.
Wow. That is an incredibly extensive list covering everything from infections and trauma to autoimmune diseases, systemic cancers, and functional issues. It really underscores why a thorough history and examination, and sometimes further testing, is absolutely necessary.
Exactly. You have to cast a wide net initially. And yet, despite this comprehensive list of possibilities to rule out, the reality, as the source reiterates throughout, is that approximately 88% of adult cases of sudden hearing loss remain idiopathic, even after a thorough search.
So a comprehensive differential diagnosis is crucial, but be prepared that most cases will still end up falling under the ISSNHL umbrella. Let's quickly recap the differential diagnosis. While 88% of cases are idiopathic, it is absolutely crucial to rule out identifiable causes. This includes retrocochlear disease, about 1%, like acoustic neuroma, MS, stroke.
Then infectious causes, meningitis, syphilis, herpes, Lyme, HIV. Traumatic causes, temporal bone fracture, barial trauma, perilymphatic fistula. Vascular causes, sickle cell vertebrobasilar insufficiency, neurological, MS again, neurosarcoidosis, neoplastic acoustic neuroma again, lymphoma, metastatic disease.
And that wide other category, including autoimmune diseases, Cogan's, Wegener's, ototoxic drugs, Meniere's disease, functional loss, and more.
Right. It's fundamentally diagnosis of exclusion, which emphasizes the need for a structured approach to the investigation. And that brings us logically to Section 12, the workup. How do we structure that investigation?
Okay, Section 12, the workup. What diagnostic steps are specifically recommended by the American Academy of Otolaryngology, AAO, for evaluating suspected SSNHL, according to our source?
The source presents 5 key recommendations from the AAO guidelines for clinicians. First, it's crucial to assess patients presenting with presumptive sudden sensorineural hearing loss for any signs of bilateral disease, recurrent episodes of SSNHL, or focal neurologic findings.
Why focus on those things initially? What's the significance?
The why here is critical. These findings are red flags. They strongly suggest underlying systemic disease, autoimmune processes, or neurological conditions that need prompt investigation and management, often going beyond just the typical ISSNHL pathway. Bilateral or recurrent loss or neurological signs make primary idiopathic SSNHL much less likely.
Okay, so rule out those red flags first by history and exam. What's the second recommendation?
Second, diagnose presumptive SSNHL if audiometry confirms the standard criteria, that 30 dB loss at 3 consecutive frequencies within 3 days, and if an underlying condition cannot be identified by the initial history and physical examination. This formalizes the need for audiometric confirmation and emphasizes that it's a presumptive diagnosis only after those initial steps have excluded obvious known causes.
Got it. And third, evaluate for retrocochlear pathology. That seems vital given the 1% risk.
Yes, absolutely. The third recommendation is to evaluate patients with diagnosed SSNHL for retrocochlear pathology. This is typically done by obtaining magnetic resonance imaging, MRI, particularly with gadolinium contrast focusing on the internal auditory canals. Alternatively, auditory brainstem response, ABR testing can be used, or sometimes just close audiometric follow-up is employed.
Why is ruling out retrocochlear pathology so important?
The why is primarily to rule out lesions like acoustic neuroma or other tumors affecting the auditory nerve, which require specific management. MRI is generally considered the gold standard imaging modality for this. ABR is a physiological test of the nerve pathway. And sometimes, even if initial tests are negative, careful audiometric follow-up can reveal progressive or asymmetric patterns suggestive of a retrocochlear lesion that wasn't initially apparent.
Okay. What about treatment considerations within this workup framework? Does the AAO workup guideline mention steroids?
Yes. The fourth recommendation specifically addresses intratympanic steroid therapy. It states clinicians should offer IT steroid therapy when patients have incomplete recovery from SSNHL after failure of initial management. This clearly positions IT steroids as a salvage option, according to this guideline, to be considered only after initial treatment, presumably systemic steroids or observation, hasn't resulted in satisfactory recovery. It's not recommended as a routine upfront treatment for everyone in this guideline step.
That's a specific timing recommendation for IT salvage. And the final recommended step in the workup. What's number 5?
Fifth, obtain follow-up audiometric evaluation within 6 months of the initial diagnosis for patients with SSNHL.
And why the follow-up audiogram? What's the purpose?
The why is multifold. To objectively document the degree of recovery, whether it was spontaneous or treatment-related, to identify patients with persistent hearing loss who may need rehabilitation counseling and intervention, and potentially to catch any evolving retrocochlear pathology that might manifest later with changes in the audiogram over time.
Okay, let's quickly recap the AAO workup recommendations. First, check for red flags: bilateral loss, recurrent episodes, focal neurologic findings. Second, confirm presumptive SSNHL with audiometry after initial history and physical exam rules out obvious known causes. Third, actively screen for retrocochlear pathology using MRI, ABR, or close audiometric follow-up. Fourth, offer IT steroids specifically as a salvage option after incomplete recovery from initial management. Fifth, ensure follow-up audiometry is obtained within 6 months.
Exactly. This provides a clear, logical, structured approach to the diagnosis and initial evaluation of patients presenting with sudden hearing loss. Now let's move from the workup to broader patient management principles in Section 13.
Right. Section 13, patient management. What do the AAO HNSF guidelines emphasize for the ongoing management of SSNHL patients, according to the source?
The source presents recent AAO HNSF guidelines that strongly recommend several key management principles.
What's the first strong recommendation for management? Where do we start?
First, perform a complete physical examination and ensure referral to an otolaryngologist. The primary goal here is to definitively distinguish sensorineural hearing loss from conductive hearing loss. The why is absolutely fundamental. The underlying cause and treatment approaches differ completely between SNHL and CHL. The specialist can perform a full otologic exam, tuning fork tests, and specialized audiometry to confirm the SNHL diagnosis.
So confirming SNHL by a specialist is foundational. What's the next crucial management step?
Second, comprehensive patient education regarding SSNHL. This is really emphasized. This education must include discussing the natural history of the condition, particularly the significant possibility of spontaneous recovery. It must also cover the potential benefits and risks of medical interventions, and importantly, acknowledge the limitations of the existing evidence regarding the efficacy of various treatments.
That sounds incredibly important for setting realistic expectations, given the uncertainties we've discussed.
Absolutely. Given the 30–60% spontaneous recovery rate and the often debated or conflicting evidence for treatments, patients need to understand the inherent uncertainty in managing ISSNHL. Counseling them honestly about the idiopathic nature, the variable outcomes, the potential side effects of treatments like steroids is key for informed consent and shared decision-making. They need to be partners in the process.
What about patients who unfortunately don't regain all their hearing? What's the guideline recommendation then?
The third strong recommendation is to counsel patients with incomplete recovery about the possible benefits of amplification, like hearing aids, hearing assistive technologies like FM systems or amplified phones, and other supportive measures. This focuses squarely on rehabilitation for those left with persistent hearing deficits.
So this means having a conversation about options for long-term support and adaptation.
Exactly. Discussing hearing aids, potentially cochlear implants if the loss is severe or profound and bilateral, other assistive listening devices, communication strategies, support groups, whatever can help them manage the remaining hearing loss and maintain their quality of life and social participation.
Okay, let's quickly recap the AAO HNSF management guidelines. First, ensure specialist referral for exam and confirmation of SNHL type. Second, provide thorough patient education covering natural history, spontaneous recovery, treatment evidence limitations, and risks versus benefits. Third, for those with incomplete recovery, counsel them on rehabilitation options like amplification and assistive technologies.
This covers the diagnostic workup and the general management principles. Now let's get into the specifics of the treatment recommendations based on the guidelines and evidence we've reviewed throughout this dive. That's Section 14.
All right, Section 14, treatment. Based on all the evidence and guidelines presented in the source material, what are the recommendations for the main therapeutic modalities? Let's start with corticosteroid therapy.
Okay, corticosteroids. The guideline recommendation presented is quite clear. Patients diagnosed with SSNHL who do not have contraindications to corticosteroid therapy should be treated with either intratympanic corticosteroids or systemic oral corticosteroids. Note the strong "should be treated" phrasing.
So steroids are strongly recommended. What's a common initial approach clinicians might take in practice?
The source suggests it is prudent or reasonable to begin with oral steroid therapy promptly, along with ensuring an urgent referral to an otolaryngologist for audiometric testing to confirm the diagnosis. A specific reasonable oral regimen mentioned is prednisone starting at 1 milligram per kilogram per day, followed by a slow taper over 2 to 3 weeks.
Okay, so start oral prednisone quickly while confirming the diagnosis. What about the decision to use IT steroids either instead of or in addition to oral?
The source emphasizes that the decision to switch to IT corticosteroids or to add IT corticosteroids to systemic therapy combination should be made through a process of shared decision-making between the patient and the referring otolaryngologist. This decision should be based on factors like the patient's response to initial therapy, the severity of the hearing loss, patient preference, and any potential contraindications to systemic therapy.
We've covered the evidence extensively, but can you quickly reiterate the key advantages of the IT route that might influence that shared decision?
Sure. The main advantages highlighted are that IT delivery results in much higher local steroid concentrations directly in the perilymph of the inner ear compared to what can be achieved safely with oral administration. This targeted high dose is thought to improve efficacy. Secondly, IT administration results in significantly fewer potential toxic systemic side effects compared to systemic regimens.
While again noting the limited data on systemic side effect prevalence with the typical short courses used for ISSNHL.
Correct. That caveat about the paucity of data for short courses is important context when discussing systemic risks.
And IT is clearly preferred for specific patient groups.
Yes, IT corticosteroids may be a better or sometimes the only option for patients who are intolerant to or refuse systemic steroid therapy or who have clear contraindications. We mentioned this before: patients with poorly controlled diabetes mellitus, those who are significantly immunosuppressed, or those with active peptic ulcer disease, for example.
Let's do a quick micro recap on corticosteroid treatment recommendations. Guidelines say steroids should be used, either IT or systemic, if no contraindications. A common initial approach is oral prednisone 1 millikilog a day with a taper, initiated promptly alongside specialist referral. The decision to use IT, switch, or add-on is a shared one with the specialist. IT advantages include higher local concentration and fewer systemic effects, making it particularly suitable for those with systemic contraindications like diabetes or PUD.
Okay, moving on to the other main therapy. Hyperbaric Oxygen Therapy. What's the guideline recommendation for HbO2? Is it as strong as for steroids? For HbO2, the guideline recommendation states that patients diagnosed with SSNHL who meet the selection criteria, which we discussed often, moderate to profound loss, usually within a certain time frame, and who do not have contraindications to HbO2 therapy may benefit from treatment. Note the softer phrasing here, may benefit, compared to the should be treated used for corticosteroids. This might reflect differences in the perceived strength or consistency of evidence, or perhaps the accessibility and logistical considerations of HbO2.
Okay, may benefit. What's the recommended treatment protocol profile for HbO2 if it is used?
The source specifies the recommended treatment profile typically involves breathing 100% oxygen at a pressure of 2.0 to 2.5 atmospheres absolute, ATA, for 90 minutes per session, administered daily for a total of 10 to 20 sessions. You can picture the patient inside the hyperbaric chamber, breathing pure oxygen under increased pressure for that duration each day.
Let's micro-recap HbO2 treatment then. Guidelines suggest patients meeting criteria with no contraindications may benefit. The typical recommended protocol involves 10-20 daily 90-minute sessions, breathing 100% O2 at 2.0-2.5 ATA pressure.
Finally, what do the guidelines say about all those other medical therapies that were listed earlier, the antivirals, vasodilators, antioxidants, etc.?
Here the recommendation is quite strong, but in the negative direction. The AAO-HNSF strongly recommends against the routine use of antivirals, thrombolytics, vasodilators, vasoactive substances, or antioxidants for patients with SSNHL. This is explicitly based on the lack of convincing evidence supporting their efficacy in the literature, aligning with those Cochrane review findings we discussed.
So despite the history of over 60 proposed protocols involving a multitude of these other medical therapies, the source concludes that only 2 therapies have actually been shown to be efficacious based on the reviewed evidence: the use of corticosteroids and HbO2 therapy.
And importantly, these 2 specific therapies are the ones endorsed by the key professional bodies cited.
Yes. The source states that corticosteroids and HbO2 have received the highest medical therapy recommendation in the guidelines for the treatment of SSNHL published by the American Academy of Otolaryngology. They are also the only 2 therapies endorsed by the UHMS committee report regarding the treatment of SSNHL.
This provides strong guideline-based support for focusing therapeutic efforts primarily on corticosteroids and HbO2.
Okay, micro recap on other therapies. Routine use of antivirals, vasodilators, thrombolytics, antioxidants, etc. is strongly recommended against by guidelines due to lack of evidence. Only corticosteroids and HbO2 are presented in the source as having evidence of efficacy and being endorsed by the relevant AAO, HNSF, and UHMS guidelines discussed.
Let's pull together the mega recap for Section 14 on treatment recommendations. Guidelines strongly recommend corticosteroid use. IT or systemic, initial, or salvage is appropriate, providing specific oral dosing parameters, prednisone 1 mg a day taper, and highlighting IT's advantages regarding local concentration and suitability for patients with systemic contraindications.
HbO2 therapy may benefit patients who meet selection criteria, moderate profound loss, ideally early presentation, and have no contraindications, with specific protocol parameters recommended: 10-20 daily sessions, 90 mins, 2.0, 2.5 ATA.
And importantly, the guidelines strongly recommend against the routine use of numerous other therapies, antivirals, vasodilators, etc., due to lack of proven efficacy, consolidating the focus on corticosteroids and HbO2 as the only two therapies endorsed by the key AAO, HNSF, and UHMS guidelines discussed in the source material as being efficacious for ISSNHL.
With treatment initiated, whether it's steroids, HbO2, or combination, what is the recommended approach for follow-up care? Section 15, follow-up.
Right, Section 15, follow-up. Once treatment is underway or has been completed, what does the source recommend for ongoing patient care?
The guideline recommendation mentioned is for continued consultation and follow-up with an otolaryngologist. It emphasizes the specialist's ongoing role.
Is there a specific role mentioned for the specialist in ongoing management during or after therapies like HbO2?
Yes, the source notes that additional testing, like repeat audiograms, and potentially further therapy, like switching to salvage IT steroids or considering amplification, may be recommended by the otolaryngologist based on the patient's response and evolving needs. It explicitly states the patient should continue to be followed by the otolaryngology specialist during and following HbO2 therapy. This really underscores the specialist's central role in monitoring outcomes closely, assessing the need for further intervention or rehabilitation planning, and coordinating the overall care plan.
Makes sense. A quick micro recap for follow-up then. Ongoing consultation and follow-up with an otolaryngologist is recommended. This is especially important for monitoring patients receiving or who have completed HbO2 therapy. The specialist will determine the need for any additional testing or changes in therapy based on the patient's progress.
Finally, let's consider the impact of this condition and the future outlook in Section 16, prognosis and cost impact.
Okay, Section 16, prognosis and cost impact. From the patient's perspective, any degree of hearing loss, especially sudden onset, imposes a significant burden. The prognosis, in terms of functional impact, is often tied to the severity of the initial hearing loss and the degree of recovery achieved. How does the source quantify the functional impact based on severity level? It links hearing loss in decibels to functional ability. Hearing loss less than 26 decibels is considered in the slight impairment range, where patients can generally hear and repeat words in a normal voice at 1 meter, though some counseling might be helpful. 2640 dB is the mild impairment range. 4160 dB is the moderate range, and 6180 dB is considered the severe range.
And it's in those moderate and severe ranges where functional communication challenges really start to emerge, right?
Exactly. The source notes that at moderate or severe levels, interventions like counseling, learning lip reading, or even sign language may be required for effective communication and participation.
How do the treatment outcomes we've discussed, like the gains seen with HbO2, relate to this functional impact? Can treatment really make a difference in daily life?
Yes, this is a key point. We saw the quantitative improvements reported with HbO2 in the Cochrane review, an average of 37.7 dBb improvement for those starting with severe loss and 19.3 dBb for those with moderate loss. The source explicitly notes that successful treatment, achieving these kinds of significant hearing gains, can potentially resolve the hearing loss towards the normal range or significantly lessen the degree of impairment.
And the significance of that for the patient's life.
It can dramatically affect a patient's quality of life. Resolving the loss or substantially improving it can potentially obviate the need for strenuous coping strategies like lip reading, signing, or heavy reliance on hearing aids. It can restore much easier communication function. You can just imagine the positive impact of regaining the ability to easily understand conversation in various settings.
Absolutely. Beyond the individual patient, what about the broader cost and burden of hearing loss on society?
The source references the World Health Organization, which has detailed the significant global cost impact of hearing loss. Financially, hearing loss impairs the ability to obtain, perform, or retain employment, leading to lost productivity. Socially, patients are often stigmatized and may become socially isolated. The overall economic burden includes the costs of specialized education, healthcare needs, and lost employment, imposing a heavy social and economic burden globally.
What is the global ranking of hearing loss as a cause of disability? How significant is it compared to other conditions?
It's remarkably high. Adult-onset hearing loss is ranked as the third leading cause of years lived with disability, YLDs, worldwide, and is projected to move up to become the seventh leading cause of overall burden of disease by the year 2030. Perhaps even more strikingly, the source states that hearing loss is the most common cause of disability globally, just ahead of other major issues like refractive errors, cataracts, and accidental injuries, which round out the top five.
Wow. The most common cause of disability globally. That's a powerful statistic that really highlights the scale of this problem. What about the cost of interventions like hearing aids for those who don't fully recover hearing naturally or with the treatment?
The source points out that for those who need them and may struggle to afford them, hearing aids cost between $1,500 and $3,000 per pair, and they typically require replacement every 3 to 5 years. This can represent a significant ongoing financial barrier to addressing the disability and improving function for many people worldwide.
Okay, let's quickly recap prognosis and cost impact from Section 16. Hearing loss severity links directly to functional impairment, often requiring specific communication strategies at moderate or severe levels. Successful treatment, achieving quantifiable gains like those reported with HBO2, can potentially push hearing towards the normal range, dramatically improving quality of life and reducing reliance on assistive strategies.
Globally, hearing loss imposes a substantial economic and social burden due to impacts on employment, potential for social isolation, and costs of specialized education and healthcare. It ranks incredibly high as the third leading cause of years lost to disability and is cited as the most common cause of disability worldwide, with projections indicating its burden will continue to grow. The significant cost of hearing aids can also be a major barrier to rehabilitation for many.
Okay, we've covered a tremendous amount of detail in this deep dive into idiopathic sudden sensorineural hearing loss, drawing specifically and extensively from the source material provided.
We really did. We started by defining the condition, recalling those critical audiometric criteria, 30 dB, 3 days, 3 frequencies, its idiopathic nature in the vast majority of cases, around 88%, and its associated symptoms like tinnitus and vertigo. We recognized it's no longer considered rare, particularly in the elderly.
We then delved deep into the complex idiopathogenesis, exploring a wide range of theories from hypoxia and various vascular issues, including that intriguing finding about hypotension in younger patients, to the now well-established strong links with cardiovascular risk factors. This led to the critical clinical pearl that ISSNHL may serve as an early warning sign for stroke, prompting specific referral recommendations for cardiology and neurology. We also touched on potential viral, immunologic, and molecular pathways like NF-key.
And this complex, often unknown causal background directly informs the challenge of treatment, explaining why over 60 protocols have been tried historically. But based on the evidence reviewed here, the source clearly identifies corticosteroids and hyperbaric oxygen therapy, particularly when used in combination, as having the greatest evidence of efficacy and being supported by relevant clinical guidelines.
We meticulously reviewed the rationale and evidence for corticosteroids, their multifaceted mechanisms of action, and the various studies supporting both systemic and intratympanic use in initial treatment as salvage therapy, and the benefits seen with combination therapy, while also acknowledging some conflicting findings in certain reviews.
We then examined HBO2 therapy, understanding its strong physiological rationale in dramatically increasing inner ear oxygenation to combat potential ischemia. We saw consistent evidence presented from numerous studies supporting its benefit as both primary treatment, often superior to medical therapy alone, and as salvage therapy after initial treatment failure. We repeatedly emphasized the critical importance of early initiation, ideally within 14 days, for maximizing HBO2 efficacy, although guidelines do offer a longer window for consideration.
The specific combination of corticosteroids and HBO2 emerged as the strategy where the source places the best evidence for hearing improvement. This was supported by studies showing superior recovery rates and, notably, significantly higher complete recovery rates highlighted by the Capilano studies striking 58% complete recovery rate for combination therapy compared to either modality alone.
We also critically reviewed the literature summary itself, noting the reliance on Class II evidence for much of the combination therapy data, but contextualizing its value. We underscored the crucial methodological limitation of the lack of convincing sham controls in all discussed HBO2 comparative studies. And we detailed the source's strong critique of specific flawed RCTs, like the Hoffman chronic ISSNHL trial, arguing they should be excluded from meta-analyses focused on acute ISSNHL.
We outlined the recommended AAO workup steps: checking for red flags, confirming SNHL audiometrically after initial HMP, actively screening for retrocochlear pathology, MRI, ABR, positioning IT steroids as a salvage option after initial management failure, and ensuring audiometric follow-up within 6 months.
And we summarized the AAO-HNSF patient management principles, ensuring specialist confirmation of SNHL type, providing comprehensive patient education, covering natural history, evidence limitations, risks, benefits, and counseling on rehabilitation strategies for those with incomplete recovery.
Finally, we consolidated the treatment recommendations. Corticosteroids should be used, IT or systemic. HBO2 may benefit eligible patients with specific parameters, and routine use of numerous other therapies is strongly recommended against, with only steroids and HBO2 endorsed by the key guidelines cited in the source as having evidence of efficacy.
And we concluded by discussing the prognosis, how hearing loss severity impacts function, but how successful treatment with quantifiable gains can restore function and quality of life. We also highlighted the significant personal, social, and economic burden of hearing loss globally, its high ranking as a cause of disability, and the barriers posed by the cost of rehabilitation aids like hearing aids.
This deep dive has certainly provided a comprehensive, unabridged exploration of ISSNHL, pulling every detail we could from the provided source material, hopefully equipping you, the specialist clinician, with the thorough understanding presented to navigate this complex condition in your practice.
Now, given the ongoing debate we've seen in the literature, the clear heterogeneity of patient response, and the persistent uncertainty about the underlying cause in most cases, a key question remains: how do we best personalize our approach to ISSNHL treatment? How do we move beyond generalized guidelines to better predict which specific patients will benefit most from which therapy, especially in the face of that causal uncertainty?
And perhaps a related thought: considering the significant global burden and the projected increase in hearing loss, how can the insights gleaned from these studies on ISSNHL treatment, particularly the potential efficacy and favorable NNT reported for therapies like HBO2 in some analyses, be leveraged to advocate for broader discussion and potentially improved access to effective treatments for this disabling condition?
These are certainly provocative thoughts for ongoing reflection and discussion as you encounter these challenging cases in your clinical work.
Thank you for joining us on this very detailed deep dive.
We hope this exploration of the source material has been valuable, and we encourage you to explore the original sources further for all the specific study details and nuances.